Greetings, good morning, good afternoon, and a very good evening to all the faculty and delegates who have joined us today from all across the world. Hope you are having an amazing day. I am Dr. Rajiv Mukherjee, and I'll be your moderator for this symposium, and I promise a great academic feast to each one of you. Humanity has witnessed a huge devastation and suffering in this pandemic. No one was untouched. We all suffered in one way or the other. We lost many of our near and dear ones. Among them, we lost Dr. Virender Mukherjee. Apart from being a renowned cornea and cataract surgeon, a mentor, teacher of teachers, we lost a very compassionate human being. To celebrate his life and academic journey, we have the who's who, the last word on cornea, as well as a star-studded panel of experts and speakers from all over the globe. I am so delighted that more than 1,400 members and delegates have pre-registered themselves and boosted our confidence to work harder for you for this symposium. Apart from the memorial portal, the streaming would be live on YouTube as well as Facebook, where it will be recorded for posterity. And we all can view them whenever you want, visit, revisit. And not to forget the delegates, they must download their certificate of participation from the memorial site. We would start with introducing the panel first. And I've requested Professor Dr. Rishi Mohan to assist me in that. So we start with, are my slides visible?
Yes, they're visible.
Yeah. Thank you. Dr. Professor G.S. Titial is Chief and Professor RP Center, AIMS, New Delhi, India. He has been honored with the Padam Shri by the President of India, and he has more than 400 publications, numerous citations, 5 books, 46 chapters, 2 patents, and his Distinguished Service Award from APAO, Senior Achievement Award from American Academy, APAO, ASCRS Certified Educator, and Peace Reddy International Award, RP Danda Award. Welcome, sir. It is an honor to have you with us. Dr. Rishi.
It's my pleasant duty and honor to introduce our chairman, Dr. William Myers, who is the assistant professor at the Northwestern University in Chicago. And he has a huge interest and contributions on ocular antisepsis and intraocular medications, and has numerous publications to his credit. He's a reviewer for the JCRS since 2002 and of the journals of Cornea and the Asia Pacific Academy of Ophthalmology. He is a member of the board of directors of the ASCRS since 2017, a president of iConnect International, and the medical director of Lighters, amongst the other distinguished positions that he occupies. We extend our heartiest welcome to Dr. Myers.
Thank you, Dr. Rishi. It's a pleasure to introduce Dr. Rishi Mohan. He's the medical director and cornea consultant at MMI Tech Institute, New Delhi, India. He did his MBBS from Maulana Azad, MD from RP Center, AIMS Fellowship Project Orbis, USA as a staff ophthalmologist in 1989, Fellowship of the Royal College of Surgeons of Edinburgh in 1996. He was awarded the gold medal and a certificate of merit for the first position at Maulana Azad Medical College and the best residence award at RP Center AIMS. He has held numerous positions in various scientific committees, and he's a fantastic person and a great friend of ours. Welcome, Dr. Rishi Mohan.
Thank you. It's my pleasant duty to also introduce our co-chairman, Dr. Virender Sangwan, director and senior cornea consultant at the Shroff Charity Eye Hospital here in New Delhi, and one of the most talented and innovative corneal surgeons with numerous contributions to his credit, especially on ocular surface disease, immunology, and corneal regeneration. He has done his fellowship in cornea and immunology at the LBPI Institute in Hyderabad and at the Harvard Medical School. He has been graced by the Dr. Shanti Swarup Bhatnagar Award for Stem Cell Research and the National Biotechnology Award, and has held the position of Medical Director of Orbis International. We welcome Dr. Virender Sangwan.
It's my pleasure to introduce Professor Ritu Arora, Dean Maulana Azad Medical College, New Delhi, Director of Ophthalmology, Guru Nanak Eye Center, New Delhi. Her principal areas of interest are cornea, refractive surgery, and ocular surface disorders. She has numerous publications and chapters in books. She's the principal investigator in 8 global trials endothelial keratoplasty training in Oregon with Dr. Mark Terry, actively involved in MBBS and MD teaching till date. She has a WHO Fellowship from Wills Eye Hospital in Toronto, P.N. Berry Fellowship, American Academy Achievement Award, Noel Moyes Oration at Cochin, WOS Oration at Delhi, and Iskeris Appreciation Award in 2017. Welcome, Professor Ritu Arora.
It's an honor to introduce and welcome Dr. Quresh Muscati to the panel on this symposium. Dr. Muscati is the medical director and the chief of Cornell services at the Muscati Eye Clinic in Mumbai. He has been the past president of the All India Ophthalmological Society, the Cornea Society of India, the Bombay Ophthalmic Association, and the Maharashtra Ophthalmic Society, amongst other positions that he has held. His trademark has always been his lucid understanding and the wit and humor that he brings to our scientific discussions. We welcome Dr. Quresh Muscati to our symposium.
It's a pleasure to introduce Professor Radhika Tandon, Professor and Unit Head, Cornea, Lens, Refractive, Ocular Oncology and Low Vision Services at All India Institute of Medical Sciences, New Delhi. Cornea, eye banking, cataract and refractive surgery, low vision and rehabilitation, genetics and epidemiology of cataract and corneal disorders, bioengineering of ocular surface and reconstruction are the fields she has actively worked in. She was awarded President of India's Silver Medal for the highest rank among women medical graduates in 1986, the Muthuswamy Gold Medal for the highest rank in ophthalmology in 1992-93, and also the IIRSI Gold Medal. She is the immediate past president of the Eye Bank Association of India and the vice president of AIBA. Welcome, Professor Tandon.
It's an honor to welcome Dr. Daya Sharma, a practicing corneal cataract and refractive surgeon from Sydney, Australia. He has trained at the Sydney Eye Hospital and had his fellowship at the Moorfields Eye Hospital in London. He has been honored by numerous awards, including the ESCRS Young Ophthalmologist Grant in 2011 and the Australian Postgraduate Award, as well as the Hampson-Sugarman Prize for Experimental Pathology. He has held the position of a RANSCO examiner and in optics and ophthalmic basic clinical examination. And he is on the medical advisory committee at the Karina Private Hospital. We welcome Dr. Daya.
Professor Vanati, a dynamic corneal surgeon, professor in ophthalmology, cornea, lens and refractive surgery at AIIMS, New Delhi. She has more than 250 international publications, numerous chapters in books, more than 200 presentations at national and international conferences, expert cataract and corneal surgeon, and a very compassionate teacher. She has received the Best of Original Papers in 2020 from the Indian Journal of Ophthalmology. She has an AIIMS Research Award credited to herself. Position held are Management Committee member of AIOS, Eye Bank Association of India, North Zone Chairperson, Delhi Ophthalmic Society Secretary, Editor, DGO, ISCRS Governing Council member, Member Scientific Committee of AIOS, Joint Treasurer AIOS, and she wears many other hats as well. Welcome, Professor Vanati.
It's a pleasure to introduce and welcome Dr. Geeta Iyer, who's a senior consultant at the Shankar Nethralaya in Chennai, and also the CJ Shah Cornea Services and the Dr. Sita Lakshmi Memorial Clinic for Ocular Surface Disease. She has had several publications and book chapters and has a special area of interest on ocular surface, including Stevens-Johnson's chemical injuries, and has performed probably the highest number of K-Pros in India. She's also the president and the founding member of the Cornea Society and has been the Indian ambassador for the International Tear Film and Ocular Surface Society and a steering member of the International K-Pro Study Group. We welcome Dr. Geeta Iyer. Dr. Rajiv Mukherjee, of course, is the person who is at the helm of this symposium. I would introduce him not only as a very worthy son of a very, very worthy and respected father, but also as a corneal surgeon of excellence in his own right, with a lot of original ideas that he has brought to the table. He's the director and senior consultant at the Mukherjee Eye Clinic in New Delhi and has numerous publications in books and the AIOS CME series. He has pioneered deep anterior lamellar keratoplasty and corneal collagen cross-linking and has been on the task force of the AIOS Cornell Infections and Ectasia programs, as well as is a certified physics and excimer laser trained physician. He's a visiting professor at the Northwestern University at Chicago and a winner of the R.N. Sabharwal Gold Medal. He has held numerous positions, including the treasurer of the ISCRIS. He's currently the vice chairman of the FPS AIOS and an executive member of the DOS in the past. We welcome Dr. Mukherjee and would request him to continue his excellent moderation.
Thank you so much, Dr. Rishi. That was a great help. I would now request Dr. Titial, Professor Titial and Dr. Myers to say a few words before we can start these academic deliberations.
Yeah, thank you, Rajiv. It's been, I think, not many days where we missed Dr. Virender Mukherjee. And this is a right way to celebrate a person who has been teacher to all of us. And I remember him being with us in every front of, not only in academics, all activities also. And he's been a great role model for all of us. And indeed, I think looking into celebrating somebody like him, an academic feast, which you have organized, a symposium on cornea, and getting people from across the world and the pioneer in their field will make this session very, very lively. I would definitely like to welcome all the delegates, people who have joined us today, the experts who are sitting here to discuss, and the speakers. On behalf of myself, the faculty, the staff of RP Center, and my own society, which Dr. Virender Mukherjee was heading earlier, the Indian Society of Cornea Refractive Surgeons. I think it will be a great learning for all of us, and congratulate you, Rajiv, for starting this type of a memorial lecture. And it will be truly a pathway for us to look into other ways also to celebrate academic achievements of our teachers. Thank you again.
Thank you so much, sir. This is only possible because of the contribution and participation that you all have shown. I'll request William Myers to say a few words.
Good day to everybody. And I've known Rajiv for over 30 years now. First, when he wanted to come to the United States, I took a chance on him. And he's grown into a great in the community. On the 2 trips that I made to India, I had a chance to drive with Gobinder and very much appreciated getting to know him. I didn't know him for his scientific aspects, but I knew him as a great family man. And I'm very proud of what Rajiv has put together today in this academic pursuit in the memory of his father.
Thank you, Bill. So let's get started. And we are now going to head into the oration, the Dr. G. Mukherjee Memorial Oration. And the speaker for the oration repeatedly makes you unlearn and then learn again and learn the new. We all knew that the cornea had 5 layers, but yet he came in and introduced the 6th layer of the cornea, the pre-Descemet's Duas layer. I am always spellbound whenever I hear him speak. His quest just goes on, and today again, he's here to talk on some amazing concepts in basic science and further relating them and translating them into a clinical structure. Dr. Dua is the director. Dr. Dua is Chair and Professor of Ophthalmology, University of Nottingham, Consultant Ophthalmology, Nottingham University Hospitals NHS Trust, Honorary Professor at the European School of Advanced Studies. His discoveries and innovations are endless, but I could just summarize a few here. Discovered the pre-Descemet's layer that I just talked about, the Duas layer in human cornea. Innovation of new surgical procedures, PDEC, DALK, triple, and suture management of acute eye drops, and he's cast light on new light on corneal pathology. He has more than 150 awards, accolades, and eponymous lectures: the Philatov Memorial Lecture, the Bowman's Lecture, the Doyne's Memorial Lecture, the honorary fellowships from multiple organizations, prestigious ones at them, editor-in-chief of the Journal of EU Cornea, the High Sheriff of Nottinghamshire, and the Commander of the Most Excellent Order of the British Empire by Her Majesty Queen Elizabeth II. It's an honor, Professor Dua, to have you with us, and I would request you to deliver the oration, and we are very keen to hear you.
Thank you very much indeed for that very kind and generous introduction. And thank you for this great honor you have bestowed on me. I'm in the process of sharing my screen, which hopefully will come up straight away. And then I should be able to proceed. So again, it's, I can't say how much an honor it is to be present at such illustrious company. I'm going to start off by a few quotes. Progress does not always equate to new discoveries and new inventions. Progress is also about understanding better what we know or think we know. Progress is about dispelling old concepts when challenged by new knowledge. Progress cuts through prejudice, and progress ultimately prevails. When we first published our account of the layer in 2013, it met with the standard 4 responses, which anything new is greeted with. It is not true. It has been described before. I have described it before. But thankfully, the majority say, let's check it out and see what this thing is. The first publication was met with this editorial by James Jester and Mark Manus. They concluded by saying that in the meantime, we should all remember the admonition from the Ecclesiasts. There is nothing new under the sun, reflecting that this has been described before. To which I responded, yes, there is nothing new under the sun, but the sun is constantly shedding new light on old objects. In science, evidence often builds over time in small increments that confirms or refutes a finding. In this Mukherjee Memorial Oration that I'm honored to deliver, under the title Understanding Clinical Pathology Through Corneal Anatomy, I will present a body of evidence not to refute or support the layer, but to demonstrate how this new finding has improved our understanding of concepts that we took for granted for many years and how they have changed. But a little about Virender Mukherjee. We have heard some of the descriptions of his illustrious career. He was a teacher, and it is said about teachers by Henry Adam, a teacher affects eternity. He can never tell where his influence will stop. Govinda was a leader. There go my men, and I must follow them, for I am their leader, is what Mahatma Gandhi is attributed to have said. And he certainly took his people with him. He was a clinician and surgeon par excellence, always putting patients above self. He was excellence personified at numerous international, national awards and accolades and the various posts he held. And I would say that he has attained immortality as he will live on through the work of the hundreds of his students that he has taught and trained. I had corresponded with him on many occasions. This was the last email I got for him when he had kindly offered me to be the first overseas honorary member of the Ocular Trauma Society of India, which I had graciously accepted and was honored to accept. And then he wrote, we are all honored to have you as a member. OSTI members are grateful to you. When you are next in Delhi, please let me know. And at that time, he was president of the Trauma Society and also president of the Eye Bank Association of India. That was not to be, but I will cherish this last email for all my professional career to come. Samuels first described Descemet's membrane detachment, and this is the first aspect of pathology that I will cover. He defined it as a detachment of the Descemet's membrane almost 100 years ago. Recently in 2020, Singh and et al. In a survey article also defined Descemet's membrane detachment as a detachment of the Descemet's membrane, which seems pretty obvious. And there was this paper in 2017 by Jodh Mehta's group where they described Descemet's membrane splitting following deep anterior lamellar keratoplasty, and they had this picture on OCT to show the split in the Descemet's membrane. We demonstrated on the basis of the pre-Descemet's layer as part of the microanatomy of the posterior cornea that Descemet's membrane detachment is not what we have thought it to be for almost 100 years. Just like the three types of bubbles that we produce when we inject air to do DALK, we have a type 1 bubble, which is the pre-Descemet's layer and the Descemet's membrane together, a type 2, which is the Descemet's membrane alone, and the mixed type, some call it type 3, where you have the type 1 and the type 2 together. In patients, you will find that Descemet's detachment follows exactly those three patterns. When it is as a straight line, like the chord of a circle, it is the combined detachment of the pre-Descemet's layer and the Descemet's membrane. When it is sinuous and wavy with a double contour line on OCT, it is like a type 2 bubble with only detachment of the Descemet's membrane. And it can be of the two together, and they are also separated from each other like a mixed bubble where the pre-Descemet's layer and the Descemet's membrane detachment. Now, this is something very recent. And if you go back and look at all your Descemet's membrane detachments, you will find these three patterns emerging, which are relevant to the management of this condition. And if you have a Descemet's membrane detachment that is torn, rhegmatogenous, then you get this coil with the endothelial cells outside. Now, here's one example after cataract surgery. Away from the center, you will see the type 1. Then you see two lines appearing, the mixed type, and then you see the pre-Descemet's detachment and the Descemet's membrane, which is torn and curled, like the mixed type, but we call it rhegmatogenous. Here's another example of a type 1. On the slit lamp, it will appear like a straight line, like the chord of a circle. This usually, almost always represents both the pre-Descemet's layer and the Descemet's membrane, which have detached. Histology on 5 cases proved that. So you have the pre-Descemet's layer, the banded and the non-banded of the zones of the Descemet's membrane in a type 1 detachment, which clinically further away from the site of the tear appears as a straight line. Here's another example of histology in a corneal graft that had failed, chronic failure, where you see the type 1, and you also see this strand extending from the posterior stroma to the detachment. Whenever you see a strand extending from the posterior stroma to the detachment, it is definitely the cleavage in the plane of the pre-Descemet's layer and the posterior cornea. Now, in histology, we find this here, the pre-Descemet's layer, and it is also infiltrated the descemetectomy.
I think we are having some internet-related issues.
Credit to Rajesh and Sharon D'Souza and others who were co-authors of the paper, and much of these images are those shared by Sharon D'Souza. And here's another example which I showed you before of that. This one by Sangeeta Wagh in a patient with on OCT, but this strangely enough recovered. The cornea recovered. New line, this retained its lining, and you can see on specular some endothelial cells. And what's more is that they were able to do cataract extraction with implant, leaving the Descemet's membrane and the pre-Descemet's detachment, i.e. the type 1 detachment as it was cataract picture. So clearly one doesn't always has to go and repair the Descemet's detachment.
Professor Dua, we're having a lag on your talk. Can you hear me, sir? I think we were having some IT-related issues. If the chairman allows, maybe we can go on to the next talk, and by the time Professor Dua joins in again, he can start where we left. So he's back.
Sorry. Can you hear me now?
Oh, much better.
Yes.
I think we lost him again. I think, Rajiv, we can go in the next oration in the meantime.
Sure, sir. Sure.
Dr. Rao is there.
The presenter for the Teacher of Teachers capsule is indeed a teacher of teacher and rightfully deserves the honor. What makes him so special in this memorial symposium is his close bond that he shared with Dr. Mukherjee since his early days in ophthalmology. He founded the prestigious L.V. Prasad Eye Institute in Hyderabad, India, a mecca of learning in cornea, where innumerable young fellows have honed their clinical and surgical skills to handle and manage the most complex cases in cornea. I'm sure you will agree, who can be better to talk on comprehensive corneal education in India than Dr. G.N. Rao. He's the distinguished chair of Eye Health, L.V. Prasad Institute of Hyderabad, India. His areas of interest are cornea, contact lens, cataract, community eye health, eye care delivery models, planning and policy. He has many named lectures and a visiting professor. His honors include that he's inducted in the Ophthalmology Hall of Fame initiated by ASCRS. He has 5 honorary doctorates, awards from many international organizations, and a World Cornea Congress medal. He presently holds the chair of L.V. Prasad Eye Institute. He's the Secretary General and Chair of the Board of International Agency for Prevention of Blindness. He is the President, Academia Ophthalmological Internationalis. I welcome Dr. Rao to deliver the Teacher of Teacher capsule oration.
Thank you, Rajiv. Let me try and share the screen. Can you see that?
Yes, sir, we can see it.
Okay. First of all, thank you so much, Rajiv, for giving me this honor to speak in a symposium commemorating one of my very first teachers in ophthalmology and cornea, the person who I always call as my Govindada. Govindada is more than an ophthalmologist. In addition to being an excellent clinician, he was a guide and a friend in the true sense of the word, sharing his knowledge, giving all kinds of encouragement for the youngsters, his juniors, and providing that much needed comfort during the days of education of any young ophthalmologist. In all these qualities, Govindada was very special. Here was a photograph shared by Rajiv during his days in RP Center, at which time I was indeed privileged to be guided by him. He was about 2.5 years ahead of me during residency. The vision for training or education of cornea is to create a workforce that can control the corneal blindness problem in India. Corneal blindness, as all of you know, is a major public health problem in Southeast Asia, Sub-Saharan Africa, and Eastern Mediterranean region. And of all these, India has the largest magnitude. We can say corneal blindness can be broadly divided into preventable and treatable categories. While the preventable category comes under the public health realm, and public health approaches work towards elimination of these problems. Education in cornea requires mainly for the treatment. Multiple aspects of cornea need education, and we also need to educate multiple cadres of eye care forces. After all, education is the one that fosters excellence. The challenge is that compared to the magnitude of corneal blindness that we have in our country, our capacity to deal with it is far lower. So when we come to treatable forms of corneal blindness, it is predominantly the role of the ophthalmologist. And currently our capacity is grossly suboptimal due to lack of education system to train adequate number of cornea specialists and to also give the knowledge in the area of cornea that is required for a comprehensive ophthalmologist in practice, and also those who are in ophthalmology training. We need to develop comprehensive cornea education centers, which deals with corneal diseases clinically, supported by very active international standard eye banks, contact lenses for post-operative visual rehabilitation and refractive surgery services, along with support from microbiology and pathology. And if we were to be truly comprehensive cornea education program, we also have to expose our trainees to prevention programs, as most of cornea blindness comes under the realm of preventive category. And we also have some unfortunate victims of corneal blindness, where despite our knowledge, techniques, and technology, we are unable to restore their sight. They need rehabilitation support. So a comprehensively trained cornea specialist should have exposure to each of these areas. In comparison, a comprehensive cornea center can do with clinical care, with support from contact lenses, refractive surgery, and microbiology. The eye banks in this locality can support the service as well as pathology services elsewhere. So this is the difference. On your left, you have a comprehensive cornea center that encompasses everything within cornea. That is what is required for an adequate training of cornea specialists. And on the right is the cornea center, where tertiary care services are provided for taking care of the corneal problems. The difference is a couple of components of the cornea. For India, it is believed that we require to perform over 100,000 corneal transplants per year, a rough estimate. So what is the vision to reach these goals and to tackle this problem? Every single residency training program in our country should have a cornea service, a corneal training program with well-qualified faculty in that subspecialty. And every tertiary care hospital should have a cornea service. In each of these, at least 1 to 2 fellowship-trained cornea specialists should be working. And then we can achieve our goals. The aim of all this is to provide the trainees a proper understanding of normal and abnormal cornea, diseases, pathology, proper ways of diagnosing disease, and all methods of treatment, both medical and surgical. In addition, they should also be exposed to prevention, rehabilitation, the most neglected areas in education and ophthalmology. Centers for cornea educators should be to prepare well-trained educators that can then work in all the medical colleges and tertiary care hospitals. It is said that when you educate a person, you can change a life. When you educate many, you can change the world. And that is indeed what we require in our country to tackle the problem of corneal blindness. These centers should have appropriate infrastructure, competent and committed faculty. Mark my words, competent and committed faculty. Competent alone will not do it. Committed alone will not do it. And an overall enabling academic environment in these centers. This could be in the form of long-term fellowships of about 2 years or so, focused programs for those who are already trained and those in practice, and online programs to reach out to more people to spread the knowledge in the area of cornea. Long-term, the aim is to create real cornea specialists. Short-term is to enhance competencies of those who are practicing cornea to some degree, but not cornea specialists, as well as trainees. And then the resident education. Long-term, comprehensive cornea care, including working in rural programs to have a global understanding of the corneal problems and what needs to be dealt with at what level. What cornea problem can be dealt with at primary, secondary, tertiary, and further up, without compromising quality at any level. For short term, it's intended for practitioners to enhance their competency. Residency must have basic minimum standards of training, and online education programs like ECO may play a significant role in reaching out to a large number of residents and provide them the proper type of education. Some lessons from our experiences in India: there is too much emphasis on surgery in our training programs, too little on making sure that the trainees have good basic understanding of corneal disease, and very little effort to make sure that they develop high quality diagnostic skills. Because each of these components is critical for proper cornea care to create a well-rounded cornea specialist. Research is possible as a career for those who are seriously interested. In addition, those who are not interested, research will give them an opportunity to develop inquiry and curiosity. That in turn enhances the clinical acumen of anybody who is exposed to research. Atul Gawande in his book Better says there are 3 core requirements for success in medicine: diligence, to do right, and ingenuity. Nowhere are these more required than in dealing with the problem of corneal blindness in India and in training appropriate number of adequately trained cornea specialists in our country. Thank you so much.
Thank you so much, sir. If you can unshare the slide. That was indeed a fantastic talk by Dr. Rao. And I believe we do have Dr. Dua back with us online. And
your technician, go ahead. Fine.
Yeah. I believe Dr. Dua is back with us. And
yeah, I think I am. I'm very sorry what happened. I don't understand what happened, but
not at all.
Is that something you can see my screen now?
Yes, we can. We can.
So I presume this is where I left off.
Yes, yes.
So thank you again, and I apologize for what happened. What I was going to show on this slide was that we have 5 patients where we have pathological confirmation. This is histopathological, where you can see on the type 1 detachment, you have the pre-Descemet's layer. Again, you don't see any cells in there, and the banded and non-banded zones of the Descemet's membrane, as you would see in a type 1 detachment or a type 1 bubble. Here's another example of chronic graft rejection and failure, where we see there's a type 1 detachment, which is the pre-Descemet's layer and Descemet's membrane. And you see the strand extending from the posterior stroma. Whenever there is collagen strand extending to the detached layer, then it is always the cleavage plane is between the pre-Descemet's layer and the posterior stroma. And in some patients, this is one of them, we were able to show that the pre-Descemet layer was infiltrated by keratocytes that came from the posterior cornea, and they then transform into myofibroblasts, and cause contractures. So when you have to treat this Descemet membrane that has undergone contracture, then you have to do a descemetectomy, otherwise it's not going to go back in place. Here's another example of a mixed detachment with the tear and the curled Descemet membrane. Here you can see two layers, the pre-Descemet layer and the Descemet membrane. And again, this I showed you before, there's the pre-Descemet layer and the torn Descemet membrane. So many of these images were contributed to by Dr. Rajesh, Sinha, and Sharon D'Souza, who were co-authors of the paper that we published at the AGO last year. This is a very interesting case sent by Sangeeta Wagh, where in a patient with Murren's ulcer, there was a type 1 detachment. As you can see here on the slit lamp, the straight chords of a circle kind of an appearance. But what was interesting is that the stroma cleared as the endothelial cells repopulated the back of the cornea, as can be seen in the specular micrograph, and they were able to do a cataract extraction and implant, leaving the detached layers in place so that the patient now has a clear cornea and some restoration of vision following cataract surgery, suggesting that you don't always have to go and peel that layer off or try to reposition it. So some new concepts emerging over there. The other area in pathology that I wanted to cover was corneal infections. Most deep corneal infections have a deep stromal abscess, and in some patients with bacterial and fungal infections, we see an intracorneal hypopyon, which can be confirmed by OCT. And the first report was by Liu et al., where they showed on histology a preferential migration of fungi in keratitis profunda, which occurred along the plane offered by the pre-Descemet layer. The stroma. Accumulation of inflammatory debris and material between the posterior stroma and that line, as you see here and here, and that suggests that there is an infiltrate in the plane of cleavage offered between the pre-Descemet layer and the deep stroma. Hypopyons have been reported by other people, many people in the past, and this is one example where you can see the cornea extends up to here, but the hypopyon, like a swallow nest, is about 2/3 of the way. Again, the detachment of the pre-Descemet layer, which most probably it is with the collection of the fluid with the levels. So when we look at intracorneal hypopyons again with OCT, we will notice that the separation is occurring at that plane of cleavage. Another important aspect is the configuration and appearance of things we see in infectious crystalline keratopathy, this needle-like crystals. When you inject air in an eye bank cornea to create a big bubble, as we were doing here, in several cases where the cornea is relatively compact and deturged, you will see these cracks in a glass-like appearance, exactly like the pattern by these needles of the crystals, telling you it's the microarchitecture of the corneal stroma that is causing this appearance to manifest. And here in this experiment, we took eye bank corneas. They were turgid, they were not in the dextran medium, and you inject bacteria into the stroma and they form clumps. This is an IOBS paper of ours from a few years ago. But if you deturgid the cornea by putting it in dextran and then inject the microorganism, no matter what organism it is, it will spread in the cornea, giving you this crystalline appearance. So the microanatomy of the cornea, rather than the type of bacteria, its species, or its biofilm, that determines this appearance of ICK. And you can see here on histology, these are bacterial colonies that, of course, in this in vitro experiment, there were no cells, no inflammatory cells, which is what we see even in vivo, because that's the definition of ICK, bacterial migration without host inflammatory response. Now, acute hydrops, now IVK describes this, as you can read over there. We all know it has always been described as a rupture of the Descemet membrane. And we postulated in our very first paper that it's not just that, it is a rupture of the descemet membrane and the pre-descemet layer. And this is the basis of that, because we had seen histology of acute eye drops where you can see the descemet and the pre-descemet layer, and with the cells now incorporating the pre-descemet layer where cells migrate into it, and again over here. And it is a rupture of both these layers that you need to get acute eye drops. And here on OCT, you can see the pre-descemet layer and the descemet layer both detached and torn together to get these fluid collections in the stroma. Now, this, of course, was a concept that was challenged initially, but then as more people started looking at it, it started becoming more obvious. Here was an acute eye drops in the pellucid. You can see the two layers, and you can see that strand. And when you see that strand, as I said, it's always showing you that the cleavage plane here is anterior to the pre-descemet layer, because you don't see strands between pre-descemet layer and the descemet membrane. You only see it between the posterior stroma and the pre-descemet layer. And on the basis of this, Professor Muran developed this operation whereby they can approximate the torn edges of the pre-descemet layer without approximating the descemet membrane, and can show very rapid resolution of acute eye drops where, by injecting air, they could delineate the length of the tear and then stitch the two together. Again, according to their quotes, that it is evidence of this layer being torn in acute eye drops and that it can be repaired. But more recently, Meles, who initially was skeptical about the layer, provided an excellent evidence by accident in patients where they were doing Bowman's membrane transplant. And what they found is when you're doing Bowman's membrane transplant and you get a detachment or a tear of the descemet membrane alone, you don't get acute eye drops. But when in thin corneas where they are dissecting the plane in the anterior stroma to insert the Bowman's membrane, and they inadvertently perforate through pre-descemet layer and descemet membrane, you always get acute eye drops. So they concluded that a tear in the pre-descemet layer is important and essential for producing acute eye drops, thereby confirming what we have said and also providing further evidence to say that a concept that we held for so many years was incorrect, in that it is only a rupture of the descemet membrane, which it isn't. And we went and enhanced that concept a little further, because when you take a human cornea in artificial anterior chamber and you try and make a slit in the back, this is a normal cornea, and then you mount it on the artificial anterior chamber and raise the pressure very high, you don't get acute eye drops. So it's not just a split in the descemet membrane and the pre-descemet layer, but it has to be in the context of the altered collagen and glycosaminoglycans of a keratoconic cornea where you get this acute eye drops. And then we, of course, responded to their paper with a letter stating that, and they responded by saying, we thoroughly agree with the primary point of the letter that acute eye drops in keratoconus was a result of a tear of both the descemet membrane and pre-descemet layer in the background of the abnormal collagen and corneal stroma in keratoconus. So that's a step ahead in our understanding of what were firmly held beliefs about acute eye drops. Now, keratoconus itself can be due to early alterations in the elastin content of the pre-descemet layer, and not just eye rubbing, etc., but a degradation of the elastin, which is whether eye rubbing contributes to that or not is a different question. And that the pre-descemet layer, a high concentration of elastin, was first demonstrated by Keith Meek using this on-face serial scanning electron microscopy procedure where all these yellow lines are elastin, and they found it was highest in the posterior 8 to 10 microns, which represents the pre-descemet layer. And they then also went on to show in keratoconus buttons that layer is attenuated. In fact, here's a keratocyte sitting on the descemet membrane with the pre-descemet layer completely gone, and the elastin becomes very less to start with and then completely disappears in the higher grades of keratoconus. So we went and tried to show the same with immunostaining and fluorescent immunostaining here. The pre-descemet layer has a high content of elastin, and the descemet membrane has it as a band on the anterior surface only. And here you can see a whole cornea where the pre-descemet layer has elastin, the interfacial matrix, and the desmus membrane with the band. And what is interesting is that if you treat the desmus membrane, which is like the DMEC membrane, with elastase enzyme, the coil spontaneously uncoils or becomes unscrolled and becomes flat. And when you do histology of that, you can see that the degradation of the elastin by the elastase as the control where it is clear. So we know that there's a lot of enzymatic changes in the pathophysiology of keratoconus, and some of these proteases are likely to be degrading the elastin in the predesmate layer and the desmus membrane to cause the onset of keratoconus, particularly posterior keratoconus. So another concept to be explored and more evidence to be generated. For many years, we have described desmetosceles as being an ectasia of the desmus membrane, but recently evidence has been provided, and I think the first paper was published by Amar Agarwal, where he called it a pre-desmocytocele, although the concept was what we had already elaborated in our very first paper, saying that some of these patients actually have the predesmate layer anterior to it. And you can see here, it's not just the desmus membrane, but also this is this patient here, and the ectasia is not a lot, but there is a predesmate layer anterior to it. And others have gone and shown that, and this is a montage prepared by Dr. Muralidhar Ramappa from LVPI. You can see there's a lot of contribution here from LV Prasad Eye Institute, of which Dr. Rao should be very proud. A very, very research-intensive institution in addition to his clinical work. So some of these are pure desmates, and some of them have predesmate stroma anterior to it. So a concept of desmetoscele also has to change, and the word predesmetoscele will become a part of the vocabulary of corneal pathology. And finish off with some miscellanea. Here's a slide of histology sent to me by Natalia from Warsaw. The patient had silver nitrate injury. Everything stained brown naturally because of the injury, but the area between the desmus membrane and the last row of keratocytes, the predesmus layer, did not stain like the rest of the cornea. So he said, concluded there's something special about that layer. And we see that also with corneal dystrophies. Lattice and granular dystrophy do not affect the layer or affect it very late, whereas in macular dystrophy, it is affected very early. This was a paper recently published, by Walter Lish and his colleague, and they found that in this patient with Lewis syndrome, there was this accumulation of discoid accumulation of a dark brown pigment, which is in the predesmate layer. They said central discoid yellow-brownish discoloration, the predesmate layer, and there are the other features of that syndrome. And this is a slit lamp showing that the deposition occurs preferentially in that layer. So there is something that we need to learn more about how it is affected in pathology of the cornea, as we are seeing in these clinical scenarios. And lastly, we will know that the predesmate layer continues imperceptibly as the trabecular meshwork. And a lot of work is being done, and some preliminary evidence to show that glaucoma and corneal biomechanics are determined by the predesmate layer and its integrity or its degradation, and it will alter accordingly. And we will see, I think, in not too distant future, the role of the layer in the pathogenesis of glaucoma and in corneal biomechanics. So my concluding statement, which is taken from this editorial I wrote for a Brazilian journal, and it's an open access journal: the eye cannot see what the mind doesn't know. And this is a famous quotation of some scientists from a while ago. But Lawrence modified it further by saying, what the eye doesn't see and the mind doesn't know doesn't exist. So that's obvious. If I don't know it and my mind can't comprehend that concept, it's not there. But what I responded by saying was, there's a difference in seeing versus looking. Only when one can look at something and see beyond what the mind knows can progress be made. And now that we have seen the layer, we know what it does, more and more discoveries and more information about its role in corneal pathology will emerge. And much has already emerged, as I've shown you, and my thanks and gratitude to the scientists and clinicians who have contributed to this knowledge. Thank you very much.
Thank you, Professor Dua. Can I have Professor Titial just to say a few words before we move on?
I think it's been an honor to listen to both the legends of our area and talking on aspects which many people would always think. As rightly pointed out, we have to really look into something to get something new out of that. Maybe people would have described something and you get into new aspects of a particular area. I fully agree with what Dr. Dua talked about. I've listened to his talk earlier also, and thinking backwards, we all realize we would have seen such things in past also. As a clinician, as a surgeon also, right from the acute eye drops to DALK surgeries, and looking into those patients with corneal problems. Yes, it was a real pleasure to listen to him. And what I can say with Dr. Rao, who's been a pioneer in building not only his own area of LV Prasad, but building the infrastructure in Andhra Pradesh and keeping our country's name always high up in the field of not only in ophthalmology, for the entire medical fraternity. In fact, we always look up to him to have some more suggestions to improve our entire infrastructure of teaching, research, academics in this country. Great listening to both of them. Thank you, Rajiv.
Thank you, sir. I think Dr. Quresh wanted to ask a question to Dr. Dua. You need to unmute yourself.
Yeah, so I basically just wanted to know, curious that first of all, why do you keep referring to it as PDL? You're in company of friends. You can say Dua's layer, and we won't think you're in the egoistical person. So we call it Dua's layer everywhere, and you keep saying PDL. So
well, I can give you a short answer. The PDL is the other full form of PDL is Prof. Dua's layer.
Wonderful.
It's not just PDL. Yeah, I think it generated a lot of controversy initially, and so I just want people to not mask the facts that are staring us in the face under the controversy of the name. So if you put that aside, then you will see what's there, which is more important than the name. But as you can see, the American Association of Ocular Oncology and Pathology, in their latest book by Yanoff and Fine, have not only acknowledged the layer, but have called it the Dua-Fine layer, because in the second edition of the book, Dr. Fine has a picture in the book. So they say he has shown this layer, but actually that picture was borrowed by Dr. Fine from a paper from previous years, and it doesn't mention or even put an arrow at the layer, but because it's in the picture, they wanted to call it the Dua-Fine layer, which is fine by me, and fine, I mean, through the pun, because the debate has shifted from whether it's there or not to what it should be called, and that is more important.
Exactly.
The question, the Professor Dua was, does it continue into Schwalbe's line or into trap meshwork?
Well, it is a trabecular meshwork, because Schwalbe's line, everybody talks about it, but if you ask even many glaucoma surgeons, which I have done, what is the histology of Schwalbe's line? And they always answer by saying, good question, which means we don't know the answer. So, and we've all used that. So the Schwalbe's line is referred to as the termination of the desmus membrane, but the desmus membrane doesn't usually have an abrupt termination. It also merges on as the basement membrane of the trabecular meshwork, on which the trabecular cells then attach. But the core of the trabecular meshwork, which is the collagen and elastin, is exactly what you see in the predesmus layer. And the evidence now shows clearly that it is a seamless transition of the predesmus cornea into the trabecular meshwork. And you can see trabecular cells in the peripheral 500 microns of the cornea. So if you draw a line joining the desmus membrane termination, which is the equivalent of Schwalbe's line, and the Bowman's, which we call anatomically as the termination of the cornea. You go central to that 500 microns, all across the circumference, you will see trabecular cells in the cornea. So this is a transition zone, and it's in an IOVS paper of 4 or 5 years ago, the evidence for this.
That was fantastic. Thank you so much, Professor Dua. I'd like to request Professor Sinha, Rajesh Sinha, he's made up a small video in memory of Dr. G. Mukherjee. Can you please do the honors?
Yeah, sure, Rajiv. Thanks, Rajiv, for allowing me to share this video. And okay. So Dr. G. Mukherjee, who was, of course, a stalwart in the field of cornea, was born in the year 1943 in Calcutta. And then he graduated from Medical College, Calcutta, and then came to RP Center. Here he did his post-graduation and then went on to become the faculty of this center, wherein he was so keen to work with in the field of cornea. He then went on to do a fellowship in the university at Vienna, and then came back again and continued his work in the field of cornea. He was very much oriented academically, and he was very much active in relation to academics. Like, he was part of various academic societies, and he contributed a lot in this field. He was involved in academics both nationally and internationally. And his area of interest, his passion was in cornea. And he went on to become the president of Delhi Ophthalmological Society in the year 1999. And then, of course, because of his achievements in various fields, in academic fields, he was awarded by various societies. Naming a few ones are the Lifetime Achievement Award from AIOS, from CSI, East Coast, Trauma Society, Eye Bank Association. And currently he was heading the Eye Bank Association of India as the president, and also as the president of the Ocular Trauma Society of India. He was active till his last breath, a very good academician, a very good father. He will always be in the hearts of all the ophthalmologists, sir. Thank you.
Thank you, Professor Rajesh. Unfortunately, it's not just Dr. Mukherjee who passed away because of this pandemic. We lost another father figure, Professor Madan Mohan. And I'll request Professor Radhika Tandon to just say a few words. I'll put up a slide.
It has indeed been a heavy loss for the cornea fraternity, with both stalwarts, Dr. G. Mukherjee and Professor Madan Mohan, leaving for the heavenly abode this year. It's so poignant that they both left a few weeks from each other. Both left due to the consequences of COVID. The thing about Dr. Madan Mohan is that any words will be less to say the entire range of achievements that Sir had. And Dr. Mukherjee was side by side with Dr. Madan Mohan in so many of his endeavors. Professor Madan Mohan was the chief of RP Center for Ophthalmic Sciences, AIIMS, and he was a champion and a legend in global ophthalmology and very much a father figure of ophthalmology in India. He is one of the key people who introduced microsurgery, and in many ways he was a surgeon par excellence, not only in his own meticulous surgical detail, his wonderful skill, but also in his mission to enable young surgeons to have all the facility required to do a good ocular surgery. And in many ways, Professor Madan Mohan actually went side by side with Dr. L.P. Agarwal. He was his right-hand man in a way. And the building up of the RP Center from scratch, Dr. L.P. Agarwal, of course, was a visionary who led from the front. And Dr. Madan Mohan was there to help him in those endeavors. And after retirement, after Dr. Madan Mohan completed his tenure at RP Center, he created a wonderful institute and also contributed to cornea surgery in the country. And Dr. G. Mukherjee actually was very much a part of his journey after that. So both of them, in a way, are together now. Dr. Madan Mohan left a few weeks after Dr. G. Mukherjee passed away. And in a way, he didn't know in his last days that because it would have been too much, too heartbreaking for him. But it's a good point to remember that the two gentlemen together sort of spent so many years doing cornea service and cornea training and did so many contributions and have, in a way, left to be together now in heaven. Dr. Madan Mohan had a phenomenal academic and research background. He did his MBBS from the very famed KGMC Lucknow, and then he joined AIIMS in 1960. He was the advisor to the Ministry of Health and Family Welfare and Armed Forces. He was a past president of Delhi Ophthalmic Society, the National Society for Prevention of Blindness, AIOS, and he also founded ISCRS, which started as the Madan Mohan Cornea Society. He was a trustee for the Bhopal Memorial Hospital Trust in Bhopal and was an expert cataract and corneal surgeon and a very compassionate teacher. And the attention he gave to the details of looking after his patients and the surgical skill is something that every student who watched him in the way he dealt with the patients in the clinic and his attention to detail during surgery, and it stayed with all of us and always will remain with us forever. His honors are innumerable. To mention a few, he was awarded the Padma Shri from the President of India and had been awarded the Lifetime Achievement Award by the All India Institute, the AIOS, DOS, Cornea Society of India, as well as ISCRS. He also had the Adenwala Oration Gold Medal, the MP Mere Distinguished Service Award, and the O.P. Bhasin Award for Science and Technology. But in a nutshell, overall, as you can see, the wonderful personality he had, he was so kind to all his patients and students and such a caring person. And he really loved RP Center and AIIMS right from his core. He had so many interests beyond ophthalmology, and it's only fitting that on this day of the Dr. G. Mukherjee Memorial Symposium, we remember both of them together with our heart full of love and gratitude for everything we have learned from them, not only in the clinic and in theater, but generally how to handle life, how to handle friendships, and how to be elegant and respectable people. So thank you so much, Rajiv, for giving me this opportunity to say the few words, and over to you to carry on.
Thank you, ma'am. We'll be now moving on to the next section, which is the Pearls of Wisdom, and we'll be going on to Dr. Pravin Krishna. He'll be talking about W, X, Y, and Z of surgery. I'm on tender hooks because Pravin really told me that this is not going to be a conventional corneal talk, and he never gave me any insight beyond that. So let's see what's coming. Pravin, can you take over? I'll unshare.
Thanks a lot, Rajiv. But again, like everyone is saying, it is an honor to be speaking on this symposium that is in honor of Professor G. Mukherjee as well as Dr. Madan Mohan. And the reason why I thought I'll pick a topic that is non-corneal, non-surgical, or non-conventional is because of the fact that when I hear people describe Dr. Mukherjee, and when you did as well, along with his keenness in perfecting keratoplasty, one of the things that actually came about was the fact that, I mean, it's people like Dr. Mukherjee who inspire people to be better surgeons as well as better doctors. And that's the reason why I thought I'd speak on something like this. But to tell you the truth, the real reason why I thought of this topic was because several months ago, one of my fellows asked me that what is it that actually makes a surgeon and how can I become a better surgeon? but I didn't have an answer to his question. But then again, I started thinking and I started reading quite a bit. And then I looked at a lot of sources if there's an answer to this. And interestingly, there are very straightforward answers. I mean, what makes a surgeon? You're supposed to enjoy the challenges. You're supposed to have technical skills. You're supposed to be able to problem solve. But it's a lot more than just these descriptors. And again, there's a lot of debate about surgeons being born or surgeons being made. And typically, when you see a great surgeon who is operating, you will think that, oh my God, this guy is so skilled. His hands are so good. And that's the typical answer that most people think of. And this is not unlike the same kind of thought process when you see a sportsman who comes once in a generation as well. That you think, oh, this guy is born a legend. And it's the same thought process that comes about with surgeons as well. But if you think about how surgeons are chosen, other than a few universities in Japan that actually test surgical dexterity when they're hiring residents, none of us actually test surgical dexterity or skills when you hire your residents or fellows. And this is something that actually comes with time, and this is something that people learn with practice. And this is where I actually would like to share something which is called the concept of the W curve from the perspective of surgery. And a short video about, let me stop sharing and share again so that I share the audio as well. This is a short video about what I think has been my learning curve in several surgeries, but more specifically related to DMEC.
I realized that there is a little more to this than just the first few cases. I almost stopped in 2015 after a series of complications and detachments that I was having. And one case that actually strikes me even today was this pediatric surgeon that I did DMEC for in 2015. I was pretty confident by then, but then it didn't work. He had a detachment and I had to convert him to a DSEC. And I was feeling really bad about what I had done and about the fact that I did not give him the expected outcome. Which is when I started to think again about the W curve that I'd mentioned a little earlier. So when you start a surgery, you start by exploring to see how this is going to work out for you. And eventually you realize that with time, with all the complications that you have, that this is not such an easy job. But then you figure out some of the ways to make sure that surgical outcomes are better. And then you become overconfident and you think, oh, this was not so tough. And this is when your second slide begins. And then most people are ready to give up. And this is the stage that you actually need to contact someone and have a mentor, which is what I did. And in 2016, I took a course for DMEC surgery. After this, it's only been one way up. And I'm pretty confident with DMEC today. And I can say that about 90% of my surgical cases for endothelial keratoplasty is DMEC, and about 10%.
So that actually just highlights one of the methods, and I have applied this sort of curve to every one of my surgeries, and I realized that it probably is true, the two troughs and the two peaks of every surgery. And this is something that you can probably correlate with as well if you've been tracking your surgeries too. And if you actually think back to the time when all of us did our residency, obviously some of us are a little older here, you will also realize that 90+% of the things that you learned in your residency are not things that you practice or that you do right now, which is the reason why it is imperative that all of us would have gone through several of these W curves at different stages of our career. And the difference whether the W is a wide W or the W is a narrow W depends on a number of factors, including the number of cases that you get to do, as well as the diligence that you actually pay to the kind of outcomes that you're having. What about the other factors? There are several other factors as well. And one of the X factors in making a surgeon is also about the fact that a surgeon is never fearful. And actually, this is a descriptor that says that sometimes a surgeon may be wrong, but you're never supposed to be in doubt. And this is a romanticized version of how a surgeon should be. But again, during residency and then during fellowship, it's because of the fact that there is lack of knowledge that there is overconfidence. And it's only later when you realize that you actually don't know a lot of things that you start to become underconfident and then become confident again with time. And all of us also have memories of those patients that we left with complications during our learning phase. And these are the patients who are responsible for the great outcomes that we have today. And in fact, surgeons a lot of times are also likened to sportsmen because of the fact that they also have this very small amount or leeway for making mistakes, because a small mistake can actually result in a big problem. And because of this, you wonder what makes them similar. And the one thing that is supposed to make them similar apparently is practice. And it's practice that actually binds all people in all areas of specialization who are at the top of their game, who actually are different from the rest of them. But how much do we practice? Actually, as surgeons, other than practicing on patients, we all expect to be perfect without adequate practice. And that probably is the difference between being a good surgeon and a great surgeon. There's several reasons why we need to practice, including improving quality, being more consistent. But then again, if you look at the qualities of a good surgeon, somebody who's conscientious, industrious, hardworking, receptive to ideas, and aware, probably the most important quality is the fact that you need to be stubborn, that you need to have the same outcomes every time you attempt to do a particular surgery. And this is the reason why you have several methods, including practicing on simulators and also practicing in the wet lab, by which you can actually practice and enhance skills. And this is the reason why during training, we realize that sometimes after we are doing surgery like cataract surgery, sometimes cataract surgery is done at the spinal level. And this is because you're unconsciously competent by now because of the fact that you spend so much time training. There are a few other factors that influence being a great surgeon, and that is about the why. Fortunately for most doctors, most of the things that we do are things that we love and things that you're good at. And this also helps make money and make a difference as well. But there comes a time in everyone's life when you start to plateau over time. And this actually is something that we can actively influence by changing our learning curve. And it seems that the key to changing our learning curve is to be able to measure yourself, because of the fact that you will not be able to measure yourself adequately with either published literature or your peers or institute outcomes or your teachers, because you don't have access to that data. And the best way in which to measure yourself is to collect your own data, benchmark your own data, and see if you're improving with time, which is all it takes to make you a better surgeon with time. And in fact, this another great book that I was reading, which says that surgeons probably are more akin to plumbers rather than sportsmen if you do not measure yourself, because sportsmen measure themselves all the time. There are also several publications about looking and learning, but then again, I would consciously say that this is not a great idea about learning surgery just by watching videos. It is not just about watching what happens in the microscope, but it is about talking to the surgeon about the thought process, looking at what happens in the OR, and looking at his movements and everything else that actually makes for comprehensive learning, and would encourage all of you trying to learn new surgery to visit someone who's already proficient in that kind of surgery. Finally, from the point of view of longevity, it's really important to build relationships, not just among your peers, but also along with your patients, because this is what is going to give you satisfaction when your surgical skills start to wane later on. The last factor that actually emphasizes the being a surgeon is the fact that surgeons, like sportsmen, also tend to have days in which they perform very well, days that are in form, and days in which they perform really badly. So what are these factors? There are several factors, but just to mention a few, it seems as if simple things like sleep deprivation on the day before surgery seems to have a significant adverse effect on your performance during surgery. Even having alcohol on the previous night before surgery reduces your surgical dexterity as well. Even having an extra coffee in the morning with extra caffeine significantly reduces your surgical skill as well as dexterity and the time that you take to perform all these maneuvers as well. On the plus side, it seems that there are a few things that can help you perform better, like warming up. Warming up does not mean doing stretches in the OR. Warming up actually means repeating the steps with your hand before you actually do the surgery, and it seems to improve the outcomes of surgery as well. Interestingly, having an adverse event during that day can also affect your performance, though we don't acknowledge this as much. But lastly, what is most important seems to be the fact that it is important to be mindful of where you are and to be present in the present to actually have great surgical outcomes and not be distracted by a lot of things. So to summarize, what I would like to share with you today, though it's a very short time, is the fact that it's important as a surgeon to keep learning with time, to keep practicing your skill, seek out peer support, and also practice mindfulness. And that is what is going to convert you from being a good surgeon into a great surgeon. Thank you very much for the opportunity again.
Thank you, Pravin. That was indeed excellent. And this is not a kind of a talk we come across every day. Can I request Dr. Virender Sangwan to say a few words on Pravin's talk? Thank you.
Thank you, Rajiv. And thank you, Pravin, for such an insightful, very intelligent analysis of a very complex topic. And you know that the surgical training globally in all fields is very poor. It's very, old and outdated system we are using. And what you have shown, if we start using these kind of techniques and tools, I'm sure the training can be enhanced. For example, the practice part. People say that if you put 10,000 hours of practice in a particular skill, whatever it may be, you can be genius in that. And it doesn't have to be on human beings. It can be on a variety of things. That's what you showed. So I think it's a very good, insightful talk. Thank you very much, Pravin.
Thanks a lot, Dr. Sangwan.
Thank you, Dr. Sangwan, and thank you, Pravin. I echo Dr. Sangwan's words, and it was really fantastic hearing you again. We'll move on to the next topic, which is Mitomycin intravascular chemo-embolization by Dr. Dean Ouano. Dean, can we have you on the, can we have you? Yeah, that's it, Dean. Hi. So Dean has sent me his presentations, but let me introduce him first. Dean is the cornea and anterior segment specialist from New Bern, North Carolina, USA. He's Duke University Eye Center Honor Day Teaching Award. He got the Penn Pearls Award from the University of Pennsylvania School of Medicine. He's Consulting Associate Faculty, Duke University Eye Center. Bill, would you like to say something before we start off with your presentation?
Thank you, Rajiv. I believe it is pre-recorded, so I'm welcome to start it.
Great, thank you.
Thank you.
Thank you, friends, for the honor of speaking to you at the Mukherjee Memorial Symposium. My name is Dr. Dean Ouano, and my topic is Mitomycin intravascular chemo-embolization, or MICE. Corneal neovascularization and lipid keratopathy is a major cause of worldwide blindness. The etiologies of lipid keratopathy include infectious, inflammatory, traumatic, and foreign body type reactions. I think that most of you will agree that the current treatment options for corneal neovascularization are less than ideal. So it's obvious that we need a better solution. MICE is an investigational procedure to eliminate corneal neovascularization and prevent visual loss in cases of lipid keratopathy threatening the visual axis. This is a healthy 59-year-old woman who developed herpes zoster-related lipid keratopathy and corneal neovascularization despite vaccination, prolonged topical steroid use, and oral antiviral use. As you can see, the central visual axis is threatened by the lipid exudation, and she had a reduction in her best corrected spectacle vision to 2100. Mitomycin at a concentration of 0.4 milligrams per milliliter was injected into the presumed feeder vessel in the peripheral cornea using a 33 gauge needle. Only a volume of 0.01 milliliter of mitomycin was necessary to blanch the entire network of blood vessels in this particular cornea. This is the appearance of the cornea on post-operative day 1. Complete regression of corneal neovascularization persists at 6 months. At 1 year follow-up, there is no remaining corneal neovascularization, and there is regression of lipid exudation. Fortunately, her best-corrected visual acuity returned to 20/20, and there was some partial resolution of her irregular astigmatism. The next mice case involves a 75-year-old woman with idiopathic lipid keratopathy, presumed to be herpes zoster. The lipid keratopathy is progressing towards the central visual axis, despite the use of topical steroids and oral antivirals. This case would prove to be more problematic to treat than the original case. As you can see, there are both deep afferent and efferent fine vessels at the limbus. In general, the afferent corneal vessels are deeper than the efferent vessels. In this case, the mice procedure involves injection of multiple afferent corneal vessels with mitomycin at very small volumes. Early postoperative interstromal hemorrhage is common after mice. 1 year after the mice procedure, there is complete resolution of corneal neovascularization without stromal ulceration, thinning, or limbal ischemia. Notice the complete absence of residual corneal neovascularization. Resolving lipid keratopathy has a sharp crystalline appearance, almost like steel wool. Before mice therapy, there's active stromal thickening. After mice therapy, there's stromal compaction with compensatory epithelial hyperplasia. Why use mitomycin for corneal neovascularization? In the field of oncology, there is precedent for the use of mitomycin for transarterial chemo-embolization of liver metastases for breast cancer and colorectal cancer. Mitomycin has a direct cytotoxic effect on endothelial cells. There is significant evidence that mitomycin causes irreversible destruction of vascular endothelium. It is important for me to emphasize that the mice procedure should be considered the treatment of last resort for progressive corneal neovascularization leading to visual loss after failed attempts at infection and inflammation control. Mice is not the primary treatment for reversible inflammatory corneal neovascularization, and mice should not be done in actively infected eyes or eyes that have an angiogenic foreign body stimulus, such as sutures. The ideal mice candidate is a patient with progressive lipid keratopathy secondary to corneal neovascularization encroaching on the visual axis. The underlying etiology of the corneal disease should be well controlled. The eye should be quiet and uninflamed. Most patients will need a trial of topical steroids and antivirals if appropriate. The recommended preoperative workup for mice includes slit lamp photography to determine the size and location of corneal blood vessels, anterior segment OCT, corneal topography to determine changes in irregular astigmatism. Many of these patients are profoundly neurotrophic, so checking corneal sensation is important. This is my current mice injection protocol. I prefer to use a TSK brand 33 gauge or JPB brand 34 gauge needle, partially filled with mitomycin in a 1 cc slit lure, not a lure lock syringe. This is the thinner gauge syringe. Make sure to remove any dead space in the syringe prior to injecting. Do not use a 30 or 32 gauge needle. they're too big. The optimum concentration of mitomycin is not yet known, but I am currently using 0.4 milligrams per milliliter. Aim for the largest bore corneal vessel just inside the limbus. Inject with enough retrograde hydrostatic force to get mitomycin into both the afferent and efferent vessels. Use a low angle of penetration, less than 15 degrees from the corneal surface, to cannulate the vessel. Even volumes as small as 0.01 ml of mitomycin should be sufficient if you are in the vessel. I have done multiple injections up to 11 with a total volume of 0.11 ml of mitomycin to ablate all actively flowing vessels. Insufficient treatment leads to reperfusion and failure. These are the two recommended needles for mice. On the left is the JPB brand 34 gauge nanoneedle, and on the right is a 33 gauge TSK needle made in Japan. I also prefer to use the more slender slip lure lock syringe, which is easier to handle and also has easier gradations on the syringe to monitor the total volume used. Mitomycin treatment can be successful with a volume as little as 0.01 ml of intravascular mitomycin, the volume of which you can see on both the left hand and right hand image. I try to inject into the largest vessels in the peripheral cornea. I avoid injecting posterior to the conjunctival insertion to avoid conjunctival hemorrhaging. Keep the surgical field dry to keep your visualization accurate. The afferent vessels are always deeper than the efferent vessels. In closing, I would propose that the mice procedure, given the right situation, can be a vision-saving option for patients with lipid keratopathy and corneal neovascularization. To this date, I've done 12 mice procedures with greater than 1 year follow-up on 4 mice patients. The results have been very good. So far, no cases of endothelial failure, corneal melting, or infectious keratitis. But of course, long-term follow-up is required. Please feel free to contact me on the email address pictured above. And once again, thank you very much, friends, for your attention. So long.
Thank you, Dean. That was indeed fantastic. I think Daya wanted to ask a few questions, but a quick questions.
Sure.
Daya, are you there?
Yes. Thank you for a great talk, Dean. It was fantastic. I just wanted to make an observation that in Professor Dua's talk, he mentioned that the sun sheds new light on old objects, and had a fantastic demonstration of how histopathology and OCT gives you a much better understanding of what's happening at the slit lamp, and we observe much better. And your use of illumination and focus is fantastic, and I think that's given us a lot better understanding of corneal neovascularization. But I wanted you to talk about how you classify lipid keratopathy.
I have 3 stages of lipid keratopathy. Stage 1, as we see in this slide right here, is the wet, soggy, melted butter stage. And this is the acute and potentially reversible phase. You can often reverse this with medical therapy, topical steroids, and antivirals. Stage 2, lipid keratopathy, is more compact, like a bar of soap. It's more chronic and not potentially as quick to reverse. Stage 3 is actually the final stages of hopefully corrected corneal neovascularization, and that's a steel wool keratopathy that you would see in slide 4 over there. That would be sharp crystalline lipid. So here in this photo right here, stage 1 lipid in the farthest reaches of the vessels. And stage 2 lipid is more chronic near the vessels. And this is a patient that slide 3 or 4, I believe, would be, that's pre-mice. And then this is post-mice. And I don't recommend mice therapy for people with lipid keratopathy involving the visual axis, but this was done on a compassionate basis. And you can see that there's resolving stage 1 wet lipid, and now transitioning to stage 2, which is more of the chronic lipid. And the final slide is a photo of a 1-year follow-up after mice. There's no corneal neovascularization, and the lipid is actually crystallizing. Hopefully, will resolve over a period of years.
Thank you, Dean. That was indeed fantastic. And I've always been fascinated with Dean's photographs, his pictures, and his concepts that are never found in books. I think Professor Dua wanted to ask a question.
Yes, thank you very much. Very exciting work. And as you probably know, we've done work on corneal vessels for a number of years. And what we found was that the commonest cause of corneal vascularization is herpetitis, zoster or simplex, and also the commonest cause of lipid keratopathy is from vessels coming from zoster or simplex, and the other kinds of vessels don't produce as much as the simplex zoster vessels do. What I found is if we do this fine needle monopolar diathermy occlusion of the vessels, that in many patients there is a permanent stromal change. So although the lipid resolves, the stromal opacification remains, and the light refraction to that will remain altered, and you then have to come in with another procedure. But obviously, once you close the vessels, the risk of rejection is less, and certainly something I'm going to go and try, and I'll be in touch with you about those needles. Where do I get those fine needles from? Thank you.
Thank you very much. I agree completely. I would say that 70% of the cases that we are treating are herpes zoster keratitis. And one of the reasons why early intervention is recommended is just as you say, once you involve the central stroma, it's very difficult to reverse those chronic changes.
I told Dean that there's going to be a flurry of questions on his topic, and it's very interesting. And I think even our panelists are very engaged with your talk. I think Professor Namrata Sharma wanted to ask something.
So I think that was a wonderful set of cases. Dean, I just wanted to ask you that we get a lot of chronic SJS which has lipid keratopathy. So what was the duration between the insult and the time of injection, that you gave? Or did you measure it from the time of a lipid keratopathy? So for how long do you think it's going to work? Just like we have with Avastin, that it only responds to the new vessels or the vessels which are newly forming and not to the chronic vessels. Do we have a similar kind of a thing for this also, Mitomycin C?
I don't know what the long-term follow-up will be, but many of these patients are presenting late onset. They have quiet eyes. They notice a white spot in their eye and the progressive visual loss. So I have not really recommended the mice procedure for people who have a hot, inflamed eye. I'm not sure I would use it on someone with Stevens-Johnson or active infection. But I think that for limited peripheral corneal neovascularization with peripheral lipid, it's a good choice.
Thank you, Dean. That was in fact very inciting, and we all enjoyed it. We'll go on to the next talk. It's by my evergreen friend Tarek. And to introduce him, let me bring up a slide. He is the head of cornea and refractive surgery at Al Noor Eye Hospital, Cairo, Egypt. His area of interest is lamellar corneal surgery, and he's very well known worldwide for it. He's the invited guest speaker in the field of lamellar corneal surgery at various international meetings. He's a professor and former head of ophthalmology, Cairo University, organizer of DMAC workshop in Cairo University. Over to you, Tarek, and we are really looking forward to your talk.
Is it clear now?
Yes, it is.
Thank you, Rajiv, for this introduction. I'm honored to be among all these distinguished speakers in the Memorial Symposium of Dr. Mukherjee. I will speak today about Big Bubble Mania. when I first started doing DALKs, I was very much amazed with the big bubble. It gives me a lot of excitement. But the big bubble surprises me many times with its unexpected behavior and strange mechanics. In this presentation, I will share with you the regular as well as the crazy types of big bubbles that I have encountered throughout my work. We'll start with the basic big bubbles. Big bubble type 1. It starts from center to the periphery, has a diameter of 8.5 millimeter, and the space, the plane of separation is between the stroma in front and Duas layer behind. And it has a characteristic white edge, as you see from this video. These are another 3 examples of big bubble type 1 with its characteristic white edge. After perfection of having big bubble from the first twice, making deeper dissection until don't lose hope that you will get the bubble at the end. Type 2 big bubble, which we call it the glassy big bubble or the predesmatic big bubble. It usually starts from the periphery to the center, and it has a large diameter, and the plane of separation is between the Duas layer in front and the descent membrane behind. It has a characteristic clear edge, as you see from this video. These another 3 examples of big bubble type 2, which I call it the glassy big bubble. As you watch in these cases, there is a glassy appearance of the big bubble, and all have the clear edge in contrast to big bubble type 1, which has a white edge. A very peculiar response of big bubble type 2. When you do paracentesis, you have to be very careful because the bubble expands tremendously, so you have to be careful, otherwise you may injure the big bubble by yourself. Watch carefully for this video. Look to this arrow. After making the big bubble type 2, now with paracentesis, the bubble will expand. As you see, it expands to occupy the whole anterior chamber, so you have to be very careful while doing paracentesis during DALK. We go now for some crazy behavior of the big bubble, what we call the mixed big bubble, or some prefer to call them big bubble type 3. We either have a complete big bubble type 1 and a partial big bubble type 2, as you see in this animation, or you may have 2 complete big bubbles, 1 and 2, which is a very rare occasion to have 2 complete big bubbles in the same patient. So we'll go through these examples. This is the example of complete big bubble type 1 with partial big bubble type 2. As you see, after opening the roof of the first bubble, you will be having this big bubble type 2, which we call it the mixed big bubble. I will go now to the most crazy behavior of the big bubble, which we have 2 bubbles on the same patient, as you see from this video. You see, this is the first big bubble type 1, and then you will be having another clear edge, big bubble type 2. You open the roof of first big bubble, and you will now having the anatomy of the cornea as if you are looking to a textbook. And you make the second brave slash, and then you will be having now the Duas layer and the descent membrane. Another example of complete big bubble type 1 and big bubble type 2. This is another example. You see, this is have 2 bubbles, the first brave slash, and then you will be having another bubble behind it, and you open it again, and then now you are cutting through Duas layer. Of course, our aim is not to cut through Duas layer, but this video was done before the clear understanding of this peculiar layer. Sometimes you have the big bubble as a friend of you. It rescue an intentional terrifying perforation. In this case, I made an intentional perforation with a terrification, but still I used the big bubble technique to rescue the case. You see the soft tension due to perforation, but fortunately enough, I have the big bubble, which allowed me to continue the case as that. Another crazy behavior of the big bubble, that sometimes you may find resistance to enlargement. For some reason or another, you find some resistance. You see, you are injecting, but the bubble doesn't want to come And then suddenly you will have the bubble expand across the terrifying edge. Another example, some resistance. But here you may help the bubble expansion by making paracentesis. So stop, make paracentesis to release the tension behind the bubble and inject again to give the chance for the bubble to expand. The collapsing big bubble is a very tricky situation in which the bubble forms and then it collapses while you are withdrawing your cannula. So you see this example, a very well-defined edge. Then while you are going down out, you will find the areas coming out with you. You do a small bubble test, negative, and then you go, you will find the bubble is present. It's hidden and it's collapsed. Another example here, when you inject and it goes out, the bubble comes with you, this by slow motion, injecting, having bubble, and then it will come all with you through the injecting track. And this is the last example of the collapsing big bubble. Watch the white edge, it will fade now because of this track. This track is the reason for collapsing of the big bubble. When we go to other infrequent behavior of the big bubble, which is called the burst big bubble. When you have the big bubble and it suddenly bursts in the anterior chamber, as you see, and sometimes you may hear a clicking sound of this burst action. You see, when it comes and then it ruptures. And this, the last example, is a partial rupture, because when you have the bubbles inside the anterior chamber, it will be trapped in the periphery. So this is a minute rupture that is still keeping the big bubble intact. Big bubble and intacts. I find no difficulty in having the big bubbles with intacts. It comes very easily, as you see. And I usually inject while the intacts are there, and I remove intacts during granular dissection. So there is no problem to have the big bubble in a previous patient with intact. But sometimes you may encounter some troubles with intacts. For example, again, the burst big bubble, because of a minute tear in the intact tunnel, and sometimes you may find also a resistance of enlargement because the intacts make some resistance for the bubble to enlarge, but you have to keep injecting until you have the full bubble. Big bubble with corneal opacities. Thanks for the big bubble that allow us to make DALK through these dense corneal scars. Since we have a normal endothelium, we can still have the big bubble in these corneal scars. This is a very good example of having the big bubble in not only a scarred cornea, but a highly vascular cornea. Imagine what will happen if we do a penetrating keratoplasty for this patient. So thanks for this big bubble that allows us to make DALK in this complicated case. Watch carefully, a lot of vascularization and the blood, and in spite of that, the big bubble allowed us to continue as DALK. This, what we call it now after Professor Dua terminology, this is a case of pre-desmatocele with some sort of corneal tissue in front of descemet membrane. In this example, I have injected air, but due to the lack of support of tissue in front, the big bubble came in an inverted direction. Look carefully here. It came in the other direction, not in the anterior chamber. I call it the inverted big bubble. And then I opened the very tiny roof of this bubble and continued my case as that. This is what I call a baby big bubble. It's very strange in this case that you have a very tiny big bubble which doesn't want to enlarge. This I just have this video for fun. And another funny video also, this a case of mixed big bubble with when we open the big bubble type 1, we have this small tiny bubble, bubble 2, in the space between Dua and descemet membrane, and I'm just dancing with this small bubble over the bubble in the anterior chamber. The peak of the big bubble mania in my career is doing DALK through the tough Dua layer after having the big bubble type 1. So this is a case of combined corneal opacity and cataract. So I have got the big bubble type 1, and knowing the strength of Dua layer, I have continued making phacoemulsification through this tough Dua layer. Again, once more, would like to thank you all for your kind attention, and I'm honored to be part of this Memorial Symposium. Thank you very much.
Thank you, Professor Katamish. That was indeed very fascinating and an excellent presentation. Thank you so much. Can Professor Ritu Arora comment?
It's always a treat to listen to Tarek and even watch his videos. And I learned so much from his different techniques. I've had numerous discussions with him. And thank you very much for, and I think with Dr. Dua telling us different anatomy of the corneal layers, this big bubble, dancing big bubble, bloody big bubble, mixed big bubble. I mean, it's very fascinating to really watch his videos and really perform the similar surgeries. But the results are excellent, so that's what keeps you going. Thank you very much, Dr. Tarek.
Thank you so much.
Thank you very much. Thank you.
We'd like to move on, and we have Dr. Rajesh Fogla with us, who will be, let me just share the screen for once.
So Rajiv, just wanted to share that with Dr. Dua's layer, we've now started to understand what we did earlier in big bubbles. I think that has, and that just explains all the type of bubbles that we ever had, which we were not able to understand earlier.
Type 1, type 2, and the mix, that all came in after the definition of Dua's layer. So that's amazing. Thank you, Dr. Dua, for that insight, and it really has changed the concept of big bubble surgery in DALK.
Thank you.
Rajesh Fogla would be, Dr. Rajesh Fogla would be talking on managing DALK Macro-Rupture. He is a director of Cornea Clinic, Hyderabad, and senior consultant at Apollo Hospital, Hyderabad. His areas of interest are lamellar corneal surgery, refractive surgery, ocular surface reconstruction. He has presented various instruction courses at international and national meetings, has numerous publications. He's a reviewer for multiple journals and innovator, and has designed multiple instruments which simplify corneal surgery. He's got the Achievement Award from American Academy, APAO meetings. He has a gold medal from Intraocular Implant and Refractive Society of India, from SIC, SSO, SIT, RAC. His oration awards at numerous meetings across India. His positions, he's a past president and the founding member of the Cornea Society of India. Welcome, Rajesh. He's a very well-known, internationally well-known lamellar corneal surgeon, and he's brought in many, many concepts that we keep learning from. Over to you.
My slides are visible?
Yes, they are.
Thank you, Rajiv, for the kind introduction. And it's a pleasure to be part of Dr. G. Mukherjee Memorial Oration meeting. And the previous speakers have already laid the foundation of my talk. And I'll be talking about macro-rupture during DALK. No financial interest to disclose. We already know that deep anterior lamellar keratoplasty, or DALK, has several advantages over traditional penetrating keratoplasty, and the foremost being the ability to retain the healthy host endothelium. These are the various steps, as Tarek has beautifully shown in his presentation, the various type of big bubbles that form, and we already know from Professor Dua's work that the separation is between the stroma and the Dua's layer, or the predecimus layer. Now here we have a case of a 24-year-old male with advanced keratoconus and has a thinnest point of 307 microns, 70.3 diopter is the steepest scale. He was intolerant to contact lens wear and wanted a surgical correction. So while doing the big bubble DALK, you can see we got a nice big bubble, but as we were expanding it, it reached up to a point and there was this sudden rupture. And that's just to show you in slow motion what happened there. You had a rupture of the bubble because the bubble went beyond the bursting pressure. And you can see that the rupture extends from one edge of the trifurcation to the other, is spindle shaped. And we had the intra-op OCT while this surgery was going on. And you can see that there is a definite break in the predecimus layer and there is a huge gap. Now what you would do traditionally in this situation is, most of us, we would convert to a penetrating keratoplasty because this large rupture is going through the visual axis. But when I did this surgery, I was thinking to myself, this is a young patient, 24-year-old, has good endothelium. Why convert to a penetrating keratoplasty? So we went ahead and started doing a manual dissection. When we reached the area of the rupture, obviously you had fluid seeping out from the anterior chamber. So we placed some sutures to secure the area which we had already dissected, and then we went ahead and dissected the the opposite quadrant, and finally we did a surgical inferior peripheral iridectomy. And this was basically because we planned to leave behind a complete airfill, and to avoid the pupillary block, we did an inferior surgical iridectomy. Now you can see that we are dissecting the stroma and carefully, just not to enlarge the rupture that's already there. And once we have removed that, you can now very clearly see the two areas of the break that you see. So we placed our graft into position and secured this with sutures all around. Once we had secured with suture, we did a airfill, and then we went with the reverse Sinski, and the edges of the break, we just manipulated the edges to kind of oppose the torn edges together. And because we had the intraoperative OCT, we could see that the gap, what we saw earlier, is no longer seen, and we gave a complete airfill, and this was basically with the intention of holding the two layers together. This is how the patient was the first post-op day and 2 weeks post-surgery. You can see that the cornea is already very clear. There is a small haze in the area of the break, and on the anterior segment OCT, you can see that the posterior layer is well opposed. And this is the pre-op topography with the post-op topography. At 3 months, his best spectacle corrected visual acuity had improved to 20/40. The central corneal thickness was about 501 microns, and the K values were 40.6 and 46.5, with the astigmatism about 5.9. He has completed 18 months of follow-up, and you can see that the cornea looks pretty clear, with just a small residual scar which is outside the visual axis. And his cornea is fairly regular, has about 3.5 diopters of astigmatism. He is 6'9", and he is off topical steroid, just using lubricant eye drops. Now, basically, what can be done to prevent a macro-rupture like this in this scenario? We know that when you are doing a big bubble, and if you don't have any point of egress of the aqueous, as the big bubble forms, the pressure within the bubble rises, and the counter pressure from the aqueous prevents the bubble from enlarging. And if you continue applying pressure to enlarge the bubble, the pressure within the bubble will increase beyond the bursting pressure, and you will have a rupture. And often we try to expand the bubble to come up to the edge of the trephination mark. This is a nice experimental study where they looked at the relationship between intraocular pressure and the size of the big bubble diameter. And they found that when the intraocular pressure is higher, the big bubble diameter is smaller, which means that the intraocular pressure determines what size of the big bubble you're going to achieve. So what modification we did was a sequential injection. We published this in JCRS last year. And you initiate the big bubble, but before you expand it further, you do a paracentesis to release the aqueous, make the eye soft, and then if you inject air, the counter pressure from the aqueous is minimized, and you can safely enlarge the bubble, minimizing the risk of a macro-rupture. So basically, in conclusion, macro-rupture in big bubble DALK can occur, and they are usually associated with the type 2 bubble, but can occur with the type 1 bubble as well. Conversion to a full thickness penetrating keratoplasty can be avoided using the technique that we have described. Intraop OCT is helpful in management of this complication. A sequential air injection with paracentesis can reduce the risk of spontaneous big bubble rupture when you are expanding it. Thank you. Thank you for your patient hearing.
It was really fantastic, Dr. Rajesh, and I don't know too many surgeons who would have thought of that and attempted that. So only in the hands of the masters can such things work out fine. Thank you so much. Excellent. I will request quick comments from Dr. Kuresh Maskati and Dr. Rishi Mohan on this.
Yeah, Rajiv, you exactly said what I wanted to say, that my heart was in my mouth when he was stroking the inner layers into position and making the gap smaller. And it was because of the intraoperative OCT that he could actually see that he was achieving what he wanted to do. And I think lesser surgeons just should admire this from afar, but I would stop at recommending this as a routine technique to be followed by people with lesser surgical skills, which is 99% of all of us attending this session. So congrats once again, Rajesh, for an excellent outcome, and again, something to be admired from afar, but perhaps prevention would be better than cure. Thanks.
Perfect. Dr. Rishi, please.
Excellent, Rajesh. It was absolutely fantastic, and I love the skill that you displayed there, as well as the quick thinking of doing a paracentesis at just the right time. It would, and I think Dr. Tarek's video also suggested that a paracentesis will reduce the intraocular pressure in the anterior chamber and allow for the bubble to expand before it actually ruptures. I am in complete agreement with what Quresh said about the skill required to try and unscroll that membrane on the back of the cornea. And I think the one thing that might have helped there would have been a continuous infusion of air, where I think Amar has shown the fish, the aquarium fish pump, where he uses a little bit of air to introduce into the anterior chamber at a low pressure. And that would have probably helped you unscroll the decimates a little better. But that was brilliant. I mean, I enjoyed that a lot. Fantastic.
I just have a quick comment. Rajesh, I think that was fantastic. I mean, like a true lamellar surgeon, we would still continue despite that macro perforation. And the best part was the solution that you showed thereof, that, you know, you have to do it sequentially. I mean, that was the best part of it. So it was just fantastic. I don't think it kind of unscrolls once you put the air bubble. You don't need a continuous air bubble because the edges are not that, you know, are not that curled up because they're still fresh.
You do kill some endothelial cells, but you're not touching it very vigorously. You are just giving it a few, you know, pull on few areas. So definitely there will be some endothelial cell loss. But overall, if you can manage to get the layer to stick and retain the patient's own endothelium, the long time would be good. And in case, if it doesn't work out for the patient, we don't lose anything by doing a subsequent penetrating keratoplasty. It would be interesting to have some comments from Professor Dua if he wants to make some points on this. What he is.
Oh, just one point. I was thinking that your rip was not any bigger or lesser than what you get in acute hydrops, but because if this was not a keratoconus patient, you probably wouldn't get acute hydrops if you didn't stroke it back. And given time, it would, the endothelium will grow and cover the gap. So for, as Quresh said, for lesser surgeons, they might just leave the gap with air and it will, the endothelium will grow over the gap.
Perfect. I think we're running very short of time, and I'd like to introduce our next speaker. He's Professor Rajesh Sinha. He's a professor of ophthalmology, cornea, lens and refractive services at All India Institute of Medical Sciences. He has got numerous publications, many textbooks and educational manuals, 87 chapters in various books. He's got the Achievement Award from American Academy, APAO, Distinguished Service Award 2020 from APAO, nominated Fellow Academy of Asia Pacific Professors of Ophthalmology, SAO Excellence Award from SARC Academy, Gold Medal from IIR, SI and ICON. He's currently the treasurer of AIOS, SARC Academy of Ophthalmology and Eye Bank Association of India. He's the General Secretary of the Indian Society of Cornea and Keratorefractive Surgeons. Professor Sinha would be talking to us on endothelial keratoplasty in difficult situations. He's gathered a good reputation of actually picking up very difficult cases where mere mortals don't tread. So, Professor Sinha, can you please share your screen and start the symposium?
Thanks a lot, Rajiv, for including me in this wonderful session wherein you know, some great stalwarts of in the field of cornea are present, and a matter of great pleasure to be a part of Dr. G. Mukherjee Memorial Symposium, whom I consider as you know, a great cornea person and like a father figure. So I'll be talking about endothelial keratoplasty in challenging situations. Endothelial keratoplasty, it has evolved over the years, and now all the cornea surgeons, we all believe that thinner is the better. So that's why, if possible, if you can do a DMEC, that would be better than a DSEC, or that's the key. But then there are certain challenging scenarios wherein you have difficulty in visualization, etc. And an ultra-thin DSEC has been found to provide some reasonably good vision and comparable, close to comparable vision and recovery of vision in comparison to DMEC in many of the conditions. And particularly, it can be performed in all types of eyes, even in those with complicated anatomy of anterior chamber and poor anterior chamber visualization. So I'll be discussing about a few of the challenging situations. Obviously, there can be many, but I will be discussing a few of the challenging situations wherein ultra-thin DSEK helps. This is a case of a twice failed graft, full thickness graft. You can see once the therapeutic graft was done and that failed, and then an optical graft was done, again a rejection was done, and there is so much of vascularization all around that a third PK will definitely fail and will have a rejection. So in such a case, an endothelial keratoplasty can help. Now in such a scenario, as far as the visibility is concerned, one can go ahead and do a DMEC. However, an ultra-thin DSEK can also provide a reasonably good outcome. The key in cases of full thickness graft wherein a DSEK, ultra-thin DSEK is being done, is that we don't prefer to score the desmase because there's some risk of dehiscence at the graft host junction. So in that case, if the desmase is not very scarred, in that case we can go ahead without scoring the desmase and put the lenticule. And there are various studies which have shown good results of ultra-thin DSEK or DSEK after failed PK. Another challenging scenario, a case of a ophthalmos. In this case, the other eye was thysical, and so an ultra-thin DSEK was planned in this eye, wherein the visibility is so poor that it is practically very difficult, I would say, to do a DMEC procedure. So an ultra-thin DSEK is being done. In this particular case, IOCT is being used, and that is really helpful in such cases because the visibility is very poor, and with the intraoperative OCT you can see how much is the fluid pocket, and in that case if it is present then you can inject more air in the anterior chamber and thereby reduce the fluid pocket. There are a couple of case reports, case series in the literature of DSEK in ophthalmos, and we also have a combined series of my cases, Dr. Namta's cases and other cases as well, and we are sending for publication. Now, DSEK in aphakia is again a very challenging scenario, and it is not that we can't do DSEK with an anterior chamber IOL, but it is advisable to do DSEK, ultra-thin DSEK in eyes with anterior chamber IOL only where the chamber is quite deep, because we want the donor lenticule to be a little away from the intraocular lens. However, it can be done in such scenarios. So it's a ultra-thin lenticule. You can see here it is folding in itself, and so a bit of tapping, etc., will be required as we do in DMEC, and then the tissue unfolds. However, it is always preferable to have the IOL a little away from the donor lenticule, as I mentioned earlier, in order to prevent the damage to the donor endothelium by the proximity of the lens and the changed hydrodynamics of the anterior chamber. And the other thing is that the lens also should be quite stable so that the hydrodynamics of the anterior chamber is not such that it causes damage to the donor endothelium. So we just wanted to know which of the two techniques, the suture fixated IOL or intrascleral haptic fixated IOL, which of the two IOLs is more stable so as to provide a good aqueous dynamics in order to prevent endothelial loss. And this is a sutured lens wherein a UBM has been done, and you can see with the movement of eyeball, the pseudophagodynosis is quite significant, quite high. It is almost touching and rubbing the iris tissue. While a case of an intrascleral haptic fixated IOL, the lens with the movement of eyeball also, the lens is quite steady. So this will not cause a lot of turbulence in the anterior chamber and will have a better outcome. And that is why we prefer doing intrascleral haptic fixation in eyes wherein we are planning to do an ultra-thin DSEK. So for this, we create a flap. I won't go into details of it due to paucity of time. So we create a scleral flap and a groove adjacent to it. And then in this case, an ACI was placed, which was almost touching the endothelium, and that way it decompensated. So the lens was removed, and then a multi-piece IOL was inserted, and the haptics exteriorized on both sides. And then the haptics were tucked into the groove. And then after tucking it into the groove, the conjunctiva was also placed back with the help of glue, and then a donor lenticule was placed in the anterior chamber and air was injected. So this is what we prefer to do in eyes wherein there is endothelial decompensation with aphakia, and this we published in the Journal of Cataract and Refractive Surgery in 2012. Now, sometimes you do have iris tissue damage as well, which requires pupilloplasty. I won't go into the video of this. This is the post-op picture after doing iris reconstruction and intravascular haptic fixation with DSEC procedure. Now, when you do all these manipulations, sometimes you can cause some damage to the donor endothelium. And then we thought that whether we should do it as a single stage or as a two stage. So we performed a comparative study between these two groups, wherein in one group, in first stage, intravascular haptic fixation of IOL was done, saniculisis and iris reconstruction, etc. was done, and second stage, ultrathin DSEC was done. And in the other group, all the things were done in one stage. And we found out that the sequential group had a better graft survival and a better outcome. This was published again in JCRS in the year 2020. In aphakic vitrectomized eye, if it's a totally vitrectomized eye, it is good to place a pars plana irrigation cannula. As you put the air inside and put the fluid on, you can see the air bubble coming up because there's a tendency for the air to go behind the iris because of the vitrectomized eye. So if you put this irrigation cannula, in the pars plana, it will push the air anteriorly, and that helps in a tamponade. Now, in eyes wherein it is not a completely vitrectomized eye, in that case, if you put a pars plana irrigation cannula, you will hydrate the vitreous more, and there is a risk of vitreous coming into anterior chamber, and that will, cause problems. So in such cases, if the globe is not firm, and most of the times it is hypotenuse, so what I do these days is I use a 30 gauge cannula, go through the pars plana, inject some fluid, and see when the globe becomes firm. Once the globe becomes firm, then I leave it like that. And I have done it in 6 eyes, and none of these eyes there was graft detachment, donor detachment on day 1, and the graft was well attached in all these eyes. Wherein because of hypotony earlier, even if the graft was showing attached in IOCT on the day of surgery, on day 1, because of hypotony, the graft used to get detached and there was some fluid pocket. So this modification has helped a lot. And this is a 1-year photograph, 1-year follow-up photograph of an eye with DSEC with the intravascular haptic fixation. Thank you very much for your patient listening. These are some of the modifications which can be done in some of these complicated scenarios. And there can be many modifications that can be done by many surgeons which suits them. Thank you very much.
Fantastic, Professor Sinha. Can I request Professor Vanati to give some comments on his presentation?
Thank you, Rajesh, for sharing some very challenging scenarios. And I know combining scleral fixated IOLs with endothelial keratoplasty is one of the most challenging scenarios, looking at their results and their how they perform postoperatively. For those surgeons who are beginning or the novice ones, what would you advise them to do sequentially or in a single stage?
Sequential definitely has a better outcome. We have done a comparative study, and we found out the sequential, because the eye becomes quiet when you are placing the tube. So there's hardly any inflammation, there's hardly anything. If you are combining it, so much of iris manipulation, so much of intraoperative manipulation can give rise to some damage to donor endothelium.
And what is the time period you would like to have between the two procedures?
Close to 3 months time when the eye is absolutely quiet. You can go a little bit earlier also, but 3 months is a very good time by which the eye is absolutely quiet. And after that, when you do this procedure, you can do it very fast and have a very good outcome.
Yeah, thank you again, Rajesh. And I think I totally agree with you. And sequential always does better, and you get lesser inflammation and better results with it. Thank you. Over to you, Raj.
Thank you so much. We'll go to the next speaker who will be talking to us on further for DMEC. And I'm sure he's a fantastic speaker, a great surgeon, and he'll motivate a lot of us to actually switch over to DMEC. And Dr. Kamran Riaz is from Oklahoma, USA. He's the Clinical Associate Professor at Dean McGee Eye Institute, University of Oklahoma, USA. His area of interest are cornea, complex cataracts, anterior segment and refractive surgery. More than 40 peer-reviewed publications. He's the chief editor of 2 textbooks. He has teaching awards in 2018 and 2019 as a Teacher of the Year. He's Achievers Under 40 award recognition by 2 state newspapers. Over to you, Kamran.
Can you see my slides?
Yes, yes.
Okay. Yes. Thank you, Rajiv Bhai, for that wonderful introduction, and it's really a pleasure and an undeserved honor to join this really distinguished panel, and I hope I can do justice to this topic here. So let me go ahead and start my presentation here. Need to go to slideshow here. Okay. I hope that's still coming through. So I'm just going to share some pearls for DMEC. I don't have any financial disclosure, but I will be talking about an instrument which I invented. Again, I don't receive any money for that particular instrument. So as Rajesh Fogla did a wonderful job talking about DSEC versus DMEC, we know that DMEC has some significant challenges, a steep learning curve. We cannot touch the tissue inside the eye, higher rate of detachment and rebubbling, and very difficulty in some complex eyes. And I think the biggest thing is a very steep learning curve, and that's what I hope to talk about today, is some things to make it very easy. And the reason is because I think most of you, certainly all of you on the panel, but many of you who are even listening internationally, are probably better surgeons than me. And when I was making the transition from DSEC to DMEC, I thought to myself, how can I make this easier for someone with limited brain cells like me? So I figure that if I can do it, then anyone can do it, and I want to share these pearls that have helped me with all of you as well. So one of the things is even before surgery, planning for these cases. I know many surgeons do intraoperative LPIs, but I found one of the things that has really cut down chances of fibrin and bleeding is to do a laser peripheral iridotomy approximately 1 week before the surgery. It saves time during the surgery and can also ensure the patency of the DMEC and minimize concern for pupillary block. I don't dilate my cases at the end. I know some colleagues do that. But one of the pearls is when you make the PI with the laser, make it infranasally to make it easier to reach across through the paracentesis. So in other words, if we're sitting here but left eye, right eye, through the paracentesis, that we can easily access that directly 180 degrees across. So here's a video kind of showing that, where you know, rather than putting the PI sort of in a very difficult to place thing here, this is a phakic eye. We have not made any main wounds. We just made a paracentesis. But because we made an inferior laser PI, it's very easy to kind of open that up during the surgery and avoid any issues there. The second pearl is actually a pearl that I learned from one of our colleagues here, Dean Ouano, who I consider to be an elder friend and mentor, which is to add Lovenox or enoxaparin to the BSS irrigation cannula. And why? Because even though whether you make an intraoperative LPI or do it you know, preoperatively, or in many of these cases, that we don't want to see fibrin, because fibrin will basically be like a rope which will prevent the graft from opening and will pull pull the graft down. So Dean shared this idea on the listserv, and that has really made my life easier. So I've added this to all cases now, and really have not seen fibrin, touch wood, since we added that. And adding this has been shown in other experimental models to reduce problems. The third thing is, many of us like to strip with a dilated pupil, or even if you do a block, you'll get some dilation, and that dilated pupil certainly helps with getting the red reflex. But using intraoperative myocol will certainly prevent the graft from migrating posteriorly, especially in pseudophakic or aphakic eyes. So here's just a video showing how powerful myocol can be to make one's life easier in these types of cases. The fourth pearl is, unlike DSEC, where if we score and we cause some iatrogenic trauma to the posterior stroma, DSEC is very forgiving. And in fact, Mark Terry has shown us that the peripheral stromal scraping may actually improve adherence of the DSEC graft in those cases. However, for DMEC, any disturbing of the stroma is not a good idea, because that can create tags and scars that will decrease the chance of attachment. So even though we all do a very good job of scoring, many of us use basically sort of a pulling maneuver to remove the scored Decimase endothelial membrane complex. And so this is sort of a device that we came up with here, which I named after my daughter, Rabia. And this is called the Rabia Decimase Membrane Removal Forceps. and it has a reverse vertical grasping action here. So this is just kind of showing how instead of like a Utrata type forceps or horizontal platform, a reverse vertical platform allows you to grab the tissue as if you're trying to grab the shirt of your enemy in order to in a confrontation. Here's what that looks like during surgery, that we have scored this eye, the Decimase membrane eye here, and after inserting the forceps, we're able to grab the scored Decimase and membrane and endothelial complex and sort of remove it sort of in one piece. And so this avoids any passing of the instrument on the posterior stroma in any of the cases, in any of the areas of the cornea, to prevent any iatrogenic and undesirable posterior stromal scarring. And this forceps works well for, this is where we're removing a failed DSEC and doing a DMEC. Here we're showing where the horizontal action of a typical microforceps is insufficient to grab the failed DSEC. And in this case, we've not had to even put in a reverse Sinski or do any type of scoring maneuvers. This is my fellow doing the case where he's able to just go in with the Rabia forceps and go 180 degrees directly across and just grab the tissue and remove it and block again by avoid any type of surgeon touch to the posterior stroma, and this makes the placement of the DMEC graft much easier. So I'll skip the end of the video for the sake of time there. The other question is, why do DMEC grafts extrude? And there's four main reasons. And the biggest reason is that when the intraocular pressure is greater than the extraocular pressure, the tissue will come out through the wound. It can also come out because of bad geometry, that if you have a longitudinal orientation, a cigar that is perpendicular to the this parallel to the wound, that it will come out. But if the cigar is perpendicular to the wound, then it will not come out. The other reason is there could be no space for the graft, or we could have a bad wound. So let's sort of show here how do we sort of insert the tissue and avoid extrusion. So one of the things can be done is to loosen up, to loosen the speculum and decrease posterior globe pressure. The other thing is to create a little safety net, a 4x4 gauze to catch in case, God forbid, the graft extrudes. And then the mantra that I like to teach our fellows is high, low, that we should have a high or slightly moderate pressure to enter the eye with the glass cannula, then lower the pressure once we are inside to kind of create space and allow the tissue to go in. When injecting the tissue, realize the pressure will go up because some VSS from the cannula will go into the eye, and it's very important to lower the pressure through the paras and make sure that the pressure is very low before coming out, and ensuring that the extraocular pressure is higher than the intraocular pressure to prevent the graft from coming out. We can also shut the door to protect the wound when exiting and make sure there are no cigars. In other words, make sure that the long axis of the DMEC graft is perpendicular to the wound before coming out. So here's an example of not doing it right. This is one of my early cases, and we can see here there's going to be a lot of high pressure. I've not lowered the pressure sufficiently. I've kept the graft to be parallel to the wound. It's not perpendicular to the wound. I think it's safe to kind of come out, and there's the disaster that has happened. So how do we prevent this from happening is by making sure we sort of do it right. So here is now, a case of doing it right. We're following the mantra of high, low, help. So here we're going in, the pressure is high, and now we have lowered it before we're injecting the tissue. And as we're getting ready to inject the tissue, it's a dynamic insertion. So one hand is inserting the tissue, and once the tissue is inside the eye, and we have now a perpendicular, at least an oblique configuration, we're going to lower the pressure, make sure the pressure is extremely low. We've also put our speculum to lower the pressure, as well as our safety net. And then we're going to shut the door to make sure that this graft does not come out. So this is an example of doing it right. But why do some of these pearls can help here? For example, if the graft is parallel to the wound and we're not careful, then it's going to basically come out straight through the wound. But even if we have some high pressure and the graft is perpendicular, what's going to happen is that the geometry can save bad pressure. So this is a clip of what I like to call that good geometry saves bad pressure. So here we're doing a case, this is actually one of the fellows doing the case, that he has a nice perpendicular orientation of the graft. We think that the pressure is low, we have tried our best to kind of decrease the intraocular pressure, and we're shutting the barn door, but still, nonetheless, we see the graft comes out. But because the geometry was perpendicular to the wound, we were able to prevent any devastating graft extrusion. Here is the benefit of so-called shutting the door and making sure you use your cannula to kind of keep the door closed. So here we're putting the graft into the eye, making sure the pressure is low, and shutting the door. So here, again, the graft came out, but because we're able to close the door, we're able to prevent a devastating extrusion, and we're able to manipulate the graft and proceed with surgery. So that is the advantage of so-called shutting the door. Other considerations, we all know about the UREC and the Drismer and when to have a shallow chamber to unfold the tissue and a deep chamber to move the tissue. But what happens if the chamber is too shallow in these long axial length and high myope type of eyes? And this pearl is to what I call use your finger. So here we have a case of using your finger. So this is a phaco-DMEC in a 28 millimeter axial length eye. We've done the phaco part, but we've noticed that the eye pressure is basically now a little too soft. So we've opened up the speculum to kind of create some pressure, and we can see the benefit of using the finger to kind of create some globe pressure, because as soon as we take the finger off, we can see that the globe pressure and the eye will basically collapse. We'll have a concave type of cornea, and even now it's very difficult to sort of open the graft in this thing. So as soon as we let go, we see the pressure kind of is gone. So this is where having a surgical assistant or the scrub nurse or somebody, you need a third hand to kind of keep the finger on the globe all throughout the process to center that graft. And by basically, you can see the whole time we've kept the finger on that graft, and until the air bubbles in, then only then we let go of the finger. So sometimes using the finger is going to be necessary in order to kind of keep the graft in a very favorable position and help it to unload. What happens if the graft is upside down? Sometimes we panic. There's a lot of talk about trying to get the graft in so that it's right side up. But if the graft is upside down, this is what I like to call the bounce pass maneuver, where we can sort of inject a jet of fluid directly at the iris and get the graft to flip without having to touch the graft. So it's not the end of the world if the graft is upside down. So here we have a case, the graft is upside down, but going in through a paracentesis here and just injecting a burst of fluid so that it bounces off of the iris and flips the graft there. So that wasn't sufficient there. So here we have to go and put in another more bunch of fluid, and we can see the graft has flipped and is in a favorable position. The final pearl that I want to share is what I like to call the Eck maneuver. This is a former fellow of mine who taught me this, where if you can get a full air fill, putting the glass cannula just sort of right at the edge of the wound will be very helpful in order to kind of get that full air fill. So here we have a case where we are injecting and we got a bubble, but we're not able to kind of get the full eye pressure, kind of the full amount of bubble. The bubble is kind of becoming small. So rather than go back into the eye and try to keep getting that bubble, if we go right at the paracentesis and just inject with like a jet stream force of air, we're able to get a full air fill for at least a few minutes before doing our final air fluid exchange. So that's a picture of the Eck maneuver. Here's another short video of that, where we're able to get the bubble, but then the Eck maneuver helps us to kind of get that deep fill by just injecting just at the edge of the graft here, just at the edge of the paracentesis, so just a burst of fluid, and we're able to sort of get that full air fill for a few minutes before normalizing the pressure there before I think. So much more to be said, and I'm sure my wonderful colleagues have many more tips, but at least for a novice like me, that these tips and pearls helped me, and I hope that these will help you in your cases, and I thank you very much for your kind attention. These are my kids, and thank you very much for your kind attention.
Thank you so much, Kamran. That was indeed fantastic, and very nice of you to name it those fantastic forceps on Rabia's name. Can I have Dr. Rishi Mohan with a quick comment on this?
Yeah, this was a wonderful, series of presentations and pearls that you've given us to put in these grafts and to ensure that we come away with a high degree of success. Excellent videos, Kamran, and excellent teaching tools that you've shown us. I especially like the forceps and the gentle curve that you've given it, and the way that you're able to peel off any membrane that's stuck to the back of the cornea without actually damaging or scoring it. And I thought that was a very good tip to have as well. Thank you very much.
Excellent. Thank you for the kind words.
We'll quickly go on to the next topic that will be taken up by Dr. Namrata Sharma, Professor Namrata Sharma. She's Professor of Ophthalmology, Corneal Lens and Refractive Surgery at AIIMS, New Delhi. She has a humongous number of publications and an encyclopedia of knowledge when it comes to corneal infections. She's a fellow from the Moorfields Eye Hospital, London, UK. She has 2 patents on Natasol and Natamatrix, which is Natamycin. Brand Ambassador for the Tear Film and Ocular Surface Society in India. Conducted numerous instruction courses nationally and internationally. She's the principal investigator, multi-centric international trials, FDA trials, and RCTs. 100 top most powerful women ophthalmologists in the world is the recognition that's been attached to her. Senior Achievement Award from the American Academy, International Ophthalmologist Education Award from the Academy, Best Video Award from ESCRS, RANSCO, and the Best Show Award 6 times by American Academy, APAO Leadership Award and Achievement Award. She is presently the Secretary of All India Ophthalmic Society, Secretary of the Eye Bank Association of India, and Chairperson Scientific Committee of ISCRS. Over to Professor Namrata Sharma.
Thank you, Dr. Rajiv, for that introduction. And I would be, to me, I think to all of us here, it has been a personal loss, and this is dedicated to the teacher of teachers and the mentor of mentors. And Dr. Mukherjee was the sitting president of the Eye Bank Association of India and a guiding light, especially in the tough times when during the COVID era, the corneas were not available. And I think his contribution to eye banking in general and specifically during those times is something which is going to be remembered by everybody. I'm going to talk to you about intracorneal antimicrobial injections, and there are no financial interests. Natasol is something which I'm going to be talking about and which is patented. And microbial keratitis continues to be one of the leading cause of blindness in the world. And although there are antimicrobials which have been given intracorneally, which include vancomycin and cefuroxime, but perhaps antibacterials don't require it that much because of good penetration. And there have been antifungals which have also been used as intracorneal drugs. It is important to know where you're there, especially in a case of microbial keratitis, because geographically the various organisms would vary depending upon your location. And fungal keratitis, although natamycin is the first line of treatment which has been shown by a MUT1 trial, it is available as suspensions which limits the corneal penetration, causes local irritation and excessive tear secretion, and the tear drug dilution may lead to drug loss. And we did, as well as other studies in their case series, show the role of intrastromal and intracorneal injections with a healing rate of almost 88%. These were the first 3 cases which we published on intrastromal injections as a targeted therapy for, especially for fungal keratitis. And then subsequently, we also published a randomized control study where we looked at topical versus intrastromal voriconazole as an adjunct to natamycin in recalcitrant fungal keratitis. Now, just to show 2 sets of cases where topical natamycin and intrastromal voriconazole was given, which resolved on therapy. And these are yet 2 more cases of the same. And there is always a issue when you're giving intracorneal injections, whether you're inciting more vascularization or not. And when we compared this with the topical therapy group, we found that there was no difference in terms of depth of vascularization or quadrants of vascularization. We also published the management algorithm for fungal keratitis, the TST protocol, or the topical systemic and targeted therapy protocol. And the idea was that the MUT1 told us that natamycin should be used alone. The MUT2 told us that systemic voriconazole should be used for keratitis, which is related to fusarium. But there was no algorithm which was present which told us when to use what and when to switch from one modality to the other. And I would like to acknowledge Professor J.S. Titial for this TST protocol, who in fact inspired us to do this study to actually tell which therapy to use when. So this is a study which was done prospectively in over 223 patients, where we did form a protocol, and then subsequently we arrived at this protocol. in case of fungal keratitis. That is, if the ulcer size is small, then topical Natamycin can be given. If there is no response, then topical voriconazole can be added. However, if the ulcer size is large with a greater involvement, then topical Natamycin and systemic antifungal can be given. And when there is no response, topical voriconazole can be added. And if there is no response to topical and systemic antifungal therapy for 4 weeks, then a targeted therapy is the one which works, which could be intrastromal, intracameral, or both, depending upon where the exudates are. So intrastromal alone or intracorneal drug alone doesn't go as an isolated drug, but goes along with intracameral if and when required. Now, this is a wonderful work which has been done in our ocular pharmacology lab by Professor Velpandian, where Natamycin suspension, which is 5%, comes as a suspension, whitish suspension like this, and he's linked it to a polymer cyclodextrin, and this has been patented. It becomes soluble like this. And this actually emanated from the fact that we first, even before we gave voriconazole, when we published in American Journal of Ophthalmology, we tried to give Natamycin, and it was not possible because it just formed a bolus sort of a thing, and it refused to move intracorneally all around the corneal abscess. So this emanated basically from that, and this is how it was prepared and was patented, and formulation is dispensed in ampules such as this, Natasol ampules. And we also looked at the pharmacokinetics in our ocular pharmacology department, where we did see that the peak concentration of Natasol is higher than that of Natamycin suspension, and remained there for a prolonged period of time as compared to Natamycin suspension. And this was also true not only for single dose kinetics, but also for multi-dose kinetics. And this is the paper which is published of the same. So we did do a study to look at the role of intracorneal injections of voriconazole, amphotericin B, and Natasol, which was available in a prospective randomized control study, with the primary outcome measure, which are as shown, the best corrected spectral visual acuity as well as time to healing, and the formation of the corneal scar. And this was in fact the intracorneal amphotericin B which is being given, and I think the technique is quite standardized. In 4 to 5 hemimeridians, you give intrastromal or intracorneal drug so as to completely encompass the lesion. And sometimes you may have to combine it with intracameral drug also, because the exudates are present intracamerally, which cannot be ignored because that infection at that level also has to be taken care of. And after injecting the intracameral voriconazole, this is the intrastromal voriconazole which is being instilled, again in 4 to 5 hemimeridians to form a barrage around the corneal abscess. Now, when we looked at all the 3 groups, they were well compared. And when we looked at the microbiology also, the positivity rate was 60 to 65%. The fungal organisms were also well compared. We needed at least 2 injections and sometimes even 4 injections to be repeated at intervals of 72 hours. And when we looked at the mean size of the epithelial defect, we found that Natamycin was superior to voriconazole, which was superior to amphotericin B. And when we looked at the mean size of the epithelial defect, voriconazole was better than amphotericin B. And comparing Natasol with amphotericin B, again, as expected, Natasol was better. In terms of stromal infiltrates as well, the mean size of the stromal infiltrates that we looked at, we found that there was a difference in the three drugs, with Natamycin, which was doing the best, followed by voriconazole, and then followed by amphotericin B. This was likewise also for the stromal infiltrate resolution, where Natasol was better as compared to amphotericin B, and this was also for a reduction in the hypopion when we compared in all the 3 categories. In time to reepithelialization, again, this was the Kaplan-Meier's failure estimates which was looked at, and intrastromal Natamycin had faster resolution than voriconazole and amphotericin B, and this was statistically significant. This is just to look at the scar size, which was comparable in all the 3, and this was the depth of the scar, which was also comparable in all the three. This was to look at the quadrants of vascularization, which was similar, and in terms of the depth of vascularization, we found that it was the vessels were deeper with amphotericin B as compared to voriconazole and soluble natamycin. And this was, of course, the best corrected visual acuity, which actually did not change between the three drugs when we looked at the final best corrected visual acuity between the three drugs. And these are some of the cases to show intrastromal natamycin, also looking at the anterior segment OCT picture. This was yet another case with intrastromal natamycin and a large ulcer with hypopion, which resolved on intrastromal natamycin. This is with intrastromal voriconazole, and yet another one with intrastromal voriconazole, and this is a third one with intrastromal voriconazole. And this was a case which, in fact, if you just look at this day one picture, possibly you would think it needs a therapeutic keratoplasty, but it actually doesn't need, and you can do a optical penetrating keratoplasty at a later date. And just to look at cases of amphotericin B, even they cause resolution. And when we compare all the three together, just I've put one representative of each, the vessels are much more with amphotericin B as compared to natasol or to voriconazole. So we concluded that intrastromal natamycin caused earlier healing of the epithelial defect and resolution of hypopion, and was as compared to voriconazole and amphotericin B. Of course, voriconazole was better than amphotericin B, and vascularization at a greater depth was seen in corneal scars where intrastromal amphotericin B was used, and this may have a bearing on the survival of the optical grafts if required at a later date. As of now, the intrastromal natamycin, it is patented, but it is now going to be marketed very soon with the microvision. All the formalities are nearly over and the paperwork is going on, and very soon it will be available in the markets in India. This is the paper that we published about the study that I was talking to you about. And this is just to show that sometimes even when you do a therapeutic keratoplasty and it kind of doesn't resolve, if you do intrastromal injections, and this was intrastromal injection of voriconazole which was being done, it does resolve. I've also come across a lot of anecdotal reports where people have not injected through the needle, but some people have, made femtosecond laser, even laser-assisted intracorneal drug delivery. Other people have inserted in the supradesmoid membrane compartment, and these are all in anecdotal reports. So I'd like to acknowledge the people who have worked in the study and in the studies related to the intrastromal injections, without whom it would not have been possible. And thank you very much for your kind attention. And this is for Dr. G. Mukherjee, who will be missed forever, but will remain in our hearts and keep guiding us as if he's still there. So thank you very much for your kind attention.
Thank you so much, Professor Namrata Sharma. And indeed, that was an excellent talk. We all might have hundreds of questions right now, but we are running out of time. This talk is so pertinent because in treating corneal infections, we just have these topical antimicrobials, oral in certain cases, but going beyond that, these intrastromal injections of antimicrobials really help heal cases. Dr. Daya and Dr. Myers, would you care to comment, a short comment on this talk, please?
Thank you for an excellent presentation. It's very humbling to be on this panel and watch you talk, because you have so much experience managing fungal keratitis. So I just want to thank you.
Thank you so much. Thank you.
Dr. Myers?
I have to admit that I'm not a cornea specialist, so I think I will defer to others.
Why I asked Bill the question was he's an expert, world-renowned expert on intracameral drugs. So hence I asked, maybe he could have given us an insight. We will actually now go over to Professor Titial if he's there. Professor Titial. Bill, you can start by giving a concluding remark to the session.
I was there. I'm missing. Yeah, let him go on.
Yeah.
Well, I've learned a lot from these lectures today, and I think they will help support the memory of Dr. Mukherjee. And I appreciate the invitation to this, and I congratulate all of the speakers.
I think Rajiv, entire symposium was wonderful, as we thought it would be a sort of a standard which will generate the enthusiasm in the young generation who have joined us today. But looking back in the entire journey of a person like Dr. Virender Mukherjee, who had started with scratch, where nothing was available, maybe a suturing was also a difficult part those days for the cornea. And today, seeing all those surgeries which are absolutely sutureless, and the rehabilitation time is like a cataract surgery nowadays. Luckily, he had seen all of them. That's a good part on his journey, that he didn't miss anything till date. So that goes with him. He was so active, not in the Cornea Forum, I rightly pointed out, in Trauma Society, in iBank, in other social activities also. I remember a lot of his associations, which I've enjoyed also in meetings, social activities, any event we have it, and they were there. Both Dr. Mukherjee and Professor Madan Mohan, and they were so active. I used to feel, my God, they are so senior and so still physically so active. And this cruel COVID has given that break with us. And I used to feel like I would learn so many things from them, because they were actually guiding us in every forum. And truly, the people who spoke today, right from the orations we had, two great people talking on orations. Then subsequently, a surgical, the scenario we saw in the videos of high quality, and closing with the newer treatment guidelines for infections, was a wonderful coverage for entirety. That's a wonderful thing, Rajiv, and congratulations for getting such a nice symposium for us tonight and the morning for other people in the eastern side. Thank you again, and wish you all the best. I hope you carry on the legacy of Dr. Virender Mukherjee to a greater height, and I know that you are fully capable on that. My regards to entire family.
Thank you so much, sir. It's just because of the faculty and the delegates and the expert panel that we have that we are here today, and that makes the symposium highly successful. I would like to really thank each and every one on the expert panel, the faculty, the speakers. They've done a wonderful job, and I feel honored because of that. I thank the delegates for the overwhelming response, and I would request them to go on the memorial site and download their certificate of participation. And I would profusely like to thank our back-end IT team, Mr. Bageshwar and Varun, who have done a stupendous job. Thank you all, and my apologies to both sides of two extremes from India, one in Australia, the others in UK and US, for odd timing of this symposium. Daya has been almost going to bed, trying to go to bed by now. And thank you so much. Thank you all.
Thank you. Thank you very much. Bye-bye.
Thank you.
Thank you very much. Well done.
Are we offline?